Over to you, Dr. Morgan.
Okay, so good morning, good morning, good morning. It's a very good morning, bright and sunny this Sunday morning. And I am here to give just say welcome to this from the Association of General Practitioners. This is our annual Ethics, Mental Health and Wellness for Healthcare Professionals virtual symposium. I would like to get right into it and invite Dr. Aldith Buckland, the Vice President of the Association of General Practitioners of Jamaica, to open the session with prayer. You're over to you, Dr. Buckland.
Thank you very much, Arna. It is really a pleasure for all of us to be here. And as we come before the throne of grace, let us kneel or mentally kneel and let us pray. Lord, as we treat our patients, help us to be wise. Let us see their problems through your discerning eyes. Guide us, Lord, and use us in everything we do. For you're the great physician, and we long to be like you. Hold on to our hands, Lord. Hold on as we hold on to you. In Jesus' name, amen.
Amen. And Dr. Buckland, Aldith, we invite you, please, to go straight into welcome and opening remarks for this session today.
Thank you very much, Dr. Morgan. Fellow participants, on behalf of the President of the Association of General Practitioners of Jamaica, Dr. Donald Gordon, I bring you welcome to this Association of General Practitioners webinar on ethics, mental health and wellness for healthcare professionals. We are called to be all things to all men. Seemingly, we are to be supermen and superwomen, and yet we are merely human. I can pinch myself and I'm flesh. And I know that we have a manual that we need to follow. And, even as Jesus needed rest, he needed time for rest and recovery, so do we. This morning, we have two wonderful presenters, and I'm so grateful that they're able to come. Drs. Frankson and Dr. Earl Wright, speaking on two important topics that we need as members: ethical aspects to healthcare versus the quality of care, and the pros and cons in an environment where we have constrained resources. And Dr. Earl Wright speaking on mental health and wellness, focusing on stress and burnout. You know, teamwork makes the dream work. We can't do it alone. And that is why we hold on to each other's hand and walk through this webinar, learning what we can so that we can implement, and hopefully our lives will be a bit easier. But together, once we are socially engaged with each other, we can help each other out. So thank you very much, and all the best for this webinar. Thank you very much, Arna.
Thank you very much to Aldith for a wonderful, warm welcome to our meeting today. And it is now over to Mr. Garth Russell from DAISY, who will give us a presentation. Mr. Russell is one of two sponsors, and very important, not only for his sponsorship, but also for his product. Please, over to you, Garth.
Hi, good morning, everyone. My name is Garth Russell, and I'm the General Manager for DAISY Health Technology. Can I share? Let me just do that. All right, so this morning, DAISY Health Technology, we're proud to sponsor this meeting, this symposium, sorry. And I just want to make a quick presentation on the company and where we are right now, because you know it's a topical issue. The security, that is the Data Protection Act. A number for now, the doctors who are now using the platform and doctors who want to use the platform, they are asking us, where are you, DAISY, with this? As an EMR, how is it that this is going to affect us? So, first of all, DAISY Health Technology is a company that was that is established, registered in Jamaica, developed in Jamaica, and is operating in Jamaica. Therefore, we must abide by all the laws that are applicable here in Jamaica. We have a certain security protocols, and we have constant auditing being done by the firm Valency Networks, and the website is given there. We will communicate this with all our users. Our compliance includes HIPAA, and the GDPR, even though it's not here. We have IWSP Top 10 certifications and ISO certifications. Now, as everyone should know what personally identifiable information are, this is not limited to, but includes names, address, phone numbers, email addresses, and financial information. Now, we do not collect financial information. However, our platform does collect other information. And therefore, it's important for us to follow what it is that is in the act for Jamaica. We have identified and assigned a data protection officer in the name of Mr. Damian Cheese, and he will ensure that all the compliance issues are dealt with. Every employee of our company will be trained. Well, they have been trained, but training will continue as long as the company operates, and that is for a very long time. We have what is called our inventory and data mapping. That is, we ensure that we have a comprehensive inventory of all the PIIs that are collected on the system and stored, and also we map, that is, we track how it is that the information flows throughout the platform and in our company. We only collect what is necessary, and that is in order to run the operations of DAISY Health Technology and any third party that we may employ to assist in the running of our platform. Again, we collect only information that is necessary and nothing else. And we retain this information for as long as it is legally required. As mentioned before, our system is encrypted, highly encrypted. Access control is maintained. and we are audited by Valency and other organizations here in Jamaica. As a matter of fact, we have an agreement with MOCA to constantly check our system to ensure that we are not breaching any laws here in Jamaica. The data subjects, that is persons whose information is collected, they have a right. They have a right to access information, rectify their information, ask that the information be removed from the system, and they have a right to know how it is that we use their information. So Daisy Health Technology is transparent in all these areas. We don't use third-party platforms at this time. Everything that is used on Daisy is developed by Daisy. However, should there be the need, we will assess their data security practices, and we will include contractual provisions to safeguard all the PIIs that are on our system. We have an incident report plan, which will be shared with all our clients. We also have internal audits, and we have an annual reporting of the audit that those audits, that are conducted throughout the year. Employee training is constant, and so we have, again, our data protection officer who is trained, very well trained, I should say, and he conducts all the trainings, and we will also employ external agencies to assist with the necessary trainings. And the contact information for Daisy is here. And that's my very, very brief presentation this morning. Thank you.
Thank you so much, Garth. You know, you've been along with us for quite a while. You're in support of us, and you're now making some of our fears clear. You know, this whole data processing thing is such a difficult topic for most of us. We don't have a great understanding of it. And the more we hear about it, the more it's like going back to school, you know, of course that should have been taught. We thank you this morning for clarification of your company's activities.
Thank you very much, Dr. Morgan. And a shameless plug, on the 14th of December, we will be hosting a training for the Data Protection Act, and this will be done by a lawyer from the OIC.
Thank you very much for that. So that's there for those who would like to participate. At this time, it is my honor to welcome Dr. Morton Anthony C. Frankson, MBBS, MPH, to participate in our conference today. Tony Frankson is one of those extremely unique individuals who gives credence first and foremostly to family. In opening, when you read about him, he states that he is married to Myris Yvette Frankson with son Gregory, daughter Jody Alisa, and granddaughter Alisa. Dr. Frankson is also an old Kingston College graduate, which was where he met Dr. Derek Aarons, another Kingston College graduate and another bioethicist who is well known to us here. Dr. Frankson is currently the president of the Bioethics Society of the English-speaking Caribbean and has secured, I think he has served as first vice president of the Jamaica Statistical Society up until last year. Dr. Frankson has a massively broad experience working in research, statistics, ethics, and epidemiology in very senior positions in the Bahamas, Turks and Caicos, California, USA, Jamaica, and with USAID. In 2004 to 2006, he also served as the Chief Medical Officer in the Ministry of Health for the government of Turks and Caicos. He has had extensive postgraduate training in public health, international and global, preventive care, epidemiology, and biostatistics, while evaluating several public health programs in the state of California. He currently is the Director of Research, Statistics, and Medical Ministry Mission for Northern Caribbean University. And he does this in Jamaica, Bahamas, Turks and Caicos Islands, and Cayman Islands. And he serves as chair of the Institutional Review Board at Northern Caribbean University. He is a founding member of the Bioethics Society in the English-speaking Caribbean. This was in 2007. And I think he's very, very proud of this. This is something that he really feels, emotional about. And he thinks he's best described as a medical doctor, health research scientist, and biostatistician. He is also very familiar with the family medicine program as practiced across the Caribbean, and he recounts having played a major part in rescuing his DM students, DM family medicine, research students, the program in the Bahamas for family medicine, lifting the pass level to 100%. That is something else that he feels good about. He's very involved with the general practitioner family medicine drive towards CME. He sees family doctors as extensionalists. I'm going to leave him to enlighten us as to what he means when he uses that term, doc. He believes in healthy lifestyles and currently enjoys climbing up the hill daily to Northern Caribbean University, which is located at the top of the hill. And he says this has taken away all his prior aches and pains. Please help me to welcome Dr. Tony Frankson, who will present to us on ethical aspects of access to healthcare versus the quality of care, the pros and cons in an environment of constrained resources. Dr. Frankson, big topic, over to you, sir.
Thank you so much, Dr. Brown Morgan. I met you yesterday, and I must have known you from many, many years ago. And I was just delighted to unite or reunite with you. And it was a fun conversation. And here we are. What I said was, I really see family medicine physicians, I see all physicians as specialists. That's really what I see. All physicians are specialists. But family medicine moves beyond that to be extensivists, community-oriented extensivists. And I look at it very broadly. I look at it that from you get the MBBS, you're a specialist, as distinct from a natural medicine or osteopathic or Chinese medicine or whatever, or dentist, etc. You're a specialist in that allopathic approach to healthcare. So you're already a specialist. That's how I look at it. You don't believe me? You take that same MBBS and you take it to America, and you are looked upon as being equivalent to a professional doctorate. And that's really anything else they do in America is add on so that they could catch up with us in the Caribbean. Because after our excellent training of 5 years plus internship plus other clinical experience, we still are just about on par. But that's debatable. And I've had many debates in the Jamaica and in the Bahamas over that. And some have fallen out with me and some have loved me for it. But I say it as I see today, tomorrow I may see it another way. So let me upload my, presentation was doing very well. Why is it going now? Oh boy. Let me see what I can do. We did our practice run and it uploaded quite nicely.
Whenever you're calling, there you
go. Is that seen by everybody?
You see the screen. Just open the presentation, and then once it's open, you can start.
Are you seeing it?
Yes, we're seeing your screen at the moment.
Are you seeing the presentation?
Not. We can see.
Because we did a practice run and it went perfectly. I don't know what happened there. Okay. Let's try it again. It's giving trouble. Technology. We're addressing that later on today. Not sure what's happening here. Okay. Let's try
Safari,
that.
can you give some instructions, please?
Able to see, are you able to open the presentation on your end, Doctor?
Not, I was able to, just while reviewing the practice session. Don't know why the computer has now lost it. So I just keep trying.
If you could just share your screen, so I could help you navigate.
Yeah, I'm on share screen right now. This particular presentation called Constrained Resources and Ethics presentation.
Right, so if you double click it, does it open? There we go. There you go.
You see it there now?
Yes, we can see it. You can start the slideshow when you're ready.
Okay, wonderful, wonderful. That is good. All righty. I'm still baffled by technology.
Can he go for right? Get rid of the slide.
Okay, so forgive me if I've changed the topic slightly. Ethical consideration on pros and cons of access to healthcare versus quality of care in constrained resources settings is what we will be talking about briefly today. I have no conflicts of interest that I know of. However, at 1 o'clock today, I will be opening the Society for English Speaking Caribbean's annual forum. And I know that that might overlap with yours, but if at some point anyone is interested, you're invited to join that as well. And, you know, our forum will be addressing aspects of technology, like outpacing moral parameters presently in existence, locally here in our different islands and in the region, and internationally too, unfortunately, even in some of the best resource countries. This is what's happening in our increasingly technological society. Now, the theme there is emerging technologies, ethical implications for the Caribbean. And I hope that that will be a benefit to you too, if you're so inclined. I want to start out with a little bit of basics in ethics for those who are new to ethics, so that you can see what it really is and what it is, what it transforms to being when it is turned into applied ethics. Let's start with Plato in his book, classic actually, The Republic. He tells the story of, in the myth of Gyges, of someone offering Gyges the opportunity to be invisible, and he could choose to do anything good or anything bad, and he wouldn't get credit for the good, and he would not be blamed for the bad. Maybe others would be. Kind of reminds me of the devil never being seen, but when something bad happens, you hear it's the act of God, but probably it's the act of the devil from Judeo-Christian worldview. So Plato asks the question there, why be moral? If you are in a position like that, where nobody could blame you or nobody could credit you, you are invisible. Why be moral? And I know many people would love to be invisible. They would prefer to be the fly on the wall, you know, there's a wallflower, etc. So it might apply for you to ask that question. Or would a person in that situation want to be moral? After long discussions in the Republic, that book, Plato concludes that it's inherently valuable, apart from any additional benefits produced or harms enabled to be avoided. Said ethics on its own is worth it. Being moral is worth it. You actually are a better blessing to your community if you have succeeded in ways that have been moral. In that same book, Socrates is reported to, after he reflected with his usual Socratic approach of always asking questions, etc., he finally made a statement which said, when he heard the whole discussion, we are discussing no small matter, but how we ought to live. Ethics interfaces with worldviews that we have, ways we see things from our cultural, etc., points of view. And some of us have decided to, have chosen to adopt a transcendental approach where it's a special thing that ethics is. It's coming down handed from some moral authority, be it Buddha, you know, be it Muhammad, be it Jesus Christ with the Beatitudes, with whatsoever you would that men should do to you, do ye even so to them, and women too, of course. And be it the Ten Commandments, be it other canons and the oracles and the pronunciations. The Judeo-Christian one is probably the one that we are most familiar with on this platform. But in the Caribbean, we have a variety of sources of moral authority. And that's intertwined in our views of the world. Our parents have taught them to us. Our churches have taught them to us. Our pastoral figures have taught them to us. Our zealous lay people have convinced us of them. And indeed, we have even claimed to have had divine encounters, some of us, where, say, the Holy Spirit has impressed them upon us. There are others who have a worldview that is more general. For example, a naturalistic persuasion or moral authority. And I'll say a little bit more about that later. But that is what energizes ethics to a large extent. And we should be grateful to the thinkers of the past who have, and of the present, who have led us into exploring these various ways philosophically of seeing what ethics is about. What ethics is not is what we call applied ethics. Applied ethics relies heavily on ethics, but it's really an aspect of sociology and not a branch of philosophy. It's really what philosophers would call a first order discipline, the thing we often call ethics, which is what we mean by is applied ethics. For example, when Prof. Waldron wrote his book, Ethics in Everyday Healthcare, it wasn't really a philosophy book for those of us who have gone through that book from cover to cover. It was really a book about how to negotiate the various dilemmas that we might face in healthcare. And I always lift my hat to Professor Waldron for taking that action. And he was a surgeon who wrote that. So he had every right to do that. And Professor Sir George Allain would back him up by reminding us that medicine itself is an aspect of sociology. And in fact, it's the first aspect that actually started our Western universities and borrowed from the Eastern universities when the West, Europe, Western Europe, etc., had no universities and would send their scholars to places like what is modern day Iraq and so forth to sit at the feet of the great Ayurvedic medics and other wonderful Ibn Sina and so forth, wonderful philosophers and practitioners of the art of medicine. People of that group have been so valuable to us as society. People of the Arabian cultures, in that they have, when Rome fell and Greece with it, the last bits of it, they preserved the writings of the Greeks, including the Hippocratic writings. We're not sure if Hippocrates really existed, but it might be a made-up figure, but he might have been a real figure, born in the Isle of Kos, about 600 years or so before, 400 or so years before Christ, or before the common era, some are prone to say now. And what is sure is that a change in thinking happened with people who are aware of that worldview, emerging worldview, and they developed what is the Hippocratic corpus, the whole body of writings that make up how you should address the art of medicine. And many of us know very well the Hippocratic Oath. It's a very religious document. It starts out swearing to the gods Asclepius and so forth, daughters Hygeia and Panacea. So it's a religious document. No apologies about that. Modern days, we have tried to sterilize it of that. And when we are doing our oath swearing ceremonies, we have a more neutered aspect version of that, or something probably quite different. But the fact is, these men laid the foundations, and indeed, as the writings got impressed upon the minds of Western Europeans in places like Padua and Salerno in Italy, they ventured to start the first universities. And the only faculty in the first universities was the medical faculty. And then after that, the lawyers and the Roman Catholic clergy, the predominant religion of that district, the Roman of the European region, etc., got jealous because they saw that going through the process of being trained as physicians in a university setting that mirrored the ones that were in Iraq and so forth, produced better persons who claimed to be physicians. The results from their patients were more consistently positive results. They weren't perfect by any means. They were still very Hippocratic physicians, very much so. And they held up to the Hippocratic Oath, and they would transmogrify it, as they were, most of them, staunch Christians of the Catholic persuasion. Now, these folks offered the Bachelor of Medicine degree, and the word bachelor there means knight. And it was the highest honor that you could get. And after, as the clergy came in, the Bachelor of Theology and Bachelor of Religion, Knight of Theology, Knight of Religion, etc. So did law, the LLB, and then, of course, the natural sciences came in as the fourth. These are the four really pure original professions Others have sprouted from that. And some we question whether they really qualify as professions because they're not as self-governing and self-moderating with ethical standards as are some like medicine and law and theology and natural science. In fact, it was not called natural sciences. It was called natural philosophy. Hence, they feel free to give you a PhD, a doctor of philosophy in the natural sciences. And that trend continued as they went on to have more and more faculties occupying the burgeoning universities that went from Europe into England and so forth, and then finally spread over to the New World. Just for us, still continuing for us who might be beginners, ethics and morality are sometimes used interchangeably. And I would like you to just let us parse that out a little bit. When we have worthy, admirable, lasting values, the Greeks would say, you are a worthy individual, you are a person of virtue. You have temperance, for example. And you can know when to say no and when to say yes, and how to use well what is safe for you and how to avoid what is harmful, etc. And they said that you had character. Well, character-wise, both, for ethics and morality, as well as for law and religion, these things should facilitate us choosing to be good people, flourishing in relationships with others, despite the seeming dilemmas, whether they be legal dilemmas, theological dilemmas, natural science dilemmas, like the James Webb Telescope is now posing on cosmologists who thought that they had the Big Bang Theory down pat, etc., or indeed ethical dilemmas. If it's ethics, we're talking about fairness, justice, truthfulness, compassion, respect, and other wonderful things like that. And the presumption here is that there is such a thing as genuine moral knowledge. Such a thing exists. You know, if you help somebody who's homeless, if you are a Mother Teresa, etc., there is such a thing as that being something that we should pay attention to and learn and know and emulate, because it came from a place, a special place. However, in modern times, there is thinking that, these are just beliefs that human beings have. That, for example, in naturalism, it's how we see reality right now, based upon the fact that we can use our senses to measure things. In other words, use an empirical approach. And the debate is hot as to whether there really is general moral knowledge, genuine moral knowledge, that some things are just good for themselves, and some things are just awful and awesome and disgusting for themselves, versus it depends upon your understanding of science. After all, everything can be reduced down to atoms and molecules and quarks and so forth. So a murder is just probably explained by a physical necessity. Some people have a hard time, including me, in swallowing that argument. Morality and ethics actually address the content, the knowledge, or as philosophers would call it, the epistemology, or the science. The word epistemology is the Greek for what the word science is for, which is to know. The knowledge part of it, I would ascribe that to be more things that morality would deal with when you're discussing the content of what is right and wrong, or good versus bad, etc. Regarding making distinctions in life's vital issues that you have to use sound arguments for. For example, in today's topic, what would a good healthcare system be here in Jamaica or there in other countries like the Bahamas? where I spent 14 years and 4 months, 14.25 years. That's morality. It looks at distinctions in what is good and bad, etc. Versus what we would say ethics handles. Ethics handles the why and the process, the artful reasoning. Did you use a logical argument when you were putting that forward? Or were you just, I feel so-and-so, and I feel so-and-so, and I feel that they shouldn't do so-and-so, Do you rise from the I feel to this is what the precedent could be, and therefore with those precedents, this is the logical conclusion of what it is. Is it formally sound, and is it also informally sound regarding what is right versus what is wrong? And there are 4 major categories.
Safari, could you check on that?
Lots there. Seems as if he fell offline, so I'm not sure if there's an issue on his end with his network connection, but it seems like he has left the Zoom. Dr. Morgan, if you have
Yes.
maybe a cell phone number for him or something, we could.
Yes, I do. So I'm
contact
actually going to give him a quick call. So
Okay.
let me come back on. Thanks, Safari. So we're just having a small technical problem because has just experienced a power cut in Mandeville. So he's trying to rejoin us on another device. Such are the vagaries of being modern and being technological in this island. So he's trying to rejoin us from another device. We'll give him a couple of minutes. If not, if we don't hear from him directly, then we'll move on perhaps to another sponsor while we give him that time to transition to wherever he needs to be to get power. So over back to you again. My apologies, everyone. Give us a few minutes. Give us a few minutes. Doc has had a complication that is totally unavoidable for himself. And so over to you, Tafari. Please let us see more about.
Okay.
Welcome to the world of Indus. And we are happy to join hands with you to serve the humanity across the globe through innovative healthcare brands. In just 16 years, Indus has grown from 1 to 120 products in 12 therapy areas. Today, Indus has spread its wings globally and is now present in 30 countries with 150 professionals spread across geographies like Asia, Southeast Asia, Africa, Europe, Caribbean, and South America. Excellence is not an act, but a habit at Indus. Our world-class products, affordable pricing, excellent supply chain, strong field force, and good business practices have accredited Indus with many excellence awards like Federation of Indian Export Organizations Export Excellence Award, Farm Excel Award, Brand of the Year Award in Ghana, and State Bank of India Financial Discipline Award. What's more, now Indus brings you a 5-minute miracle. In today's fast and modern lifestyle, the incidence of heartburn due to acid reflux and GERD is alarming due to stress and busy schedules, overeating, eating irregularly or too quickly, eating just before bedtime, fatty, spicy and fried junk foods, caffeinated drinks, carbonated soft drinks, acidic juices and alcohol, and smoking. As published in many international journals, hyperacidity, acid reflux and GERD lead to heartburn. In hyperacidity, the excess acid from the stomach can move upward into the esophagus, known as acid reflux. As the lower esophageal sphincter, which joins the esophagus and stomach, becomes weak. Since the esophagus is not well protected like the stomach, the acid can irritate the lining and cause inflammation in the esophagus. This causes painful symptoms that can last for a few minutes to hours and can occur more frequently within a week. This chronic form of acid reflux is known as GERD, that is, gastroesophageal reflux disease. The major symptoms of heartburn due to acid reflux and GERD are a burning feeling in the chest, epigastric pain, a bitter or sour taste in the mouth, nausea after eating, regurgitation, frequent burping, flatulence and gas, stomach discomfort, difficulty in swallowing, sore throat and dry cough. The question now is, do regular antacids help? In hyperacidity and GERD, regular antacids can only neutralize the acids, leaving acid reflux unattended. To treat hyperacidity, acid reflux and GERD, Indus Life Sciences comes with a unique third-generation antacid named NewGel, which controls acidity, prevents reflux. NewGel offers balanced combination of alginic acid, magnesium hydroxide, dried aluminum hydroxide, magnesium trisilicate, and dimethicone. When a person takes NewGel, the raft-forming alginate physically blocks reflux through a unique mechanism. When alginic acid comes in contact with the gastric acid, the raft-forming alginate, which includes natural algae, begins to form a light but strong foam barrier known as raft. This raft floats on top of the stomach contents and prevents acid from moving upward to the esophagus. The alginate raft formula, containing balanced antacid components, offers a speedy onset of action in less than 5 minutes and provides rapid relief from acid reflux with effective neutralization of stomach acid. NewGel has long-lasting effects up to 4 hours, since the raft can be retained in the stomach for several hours. Dimethicone in NewGel is an anti-foaming agent. It reduces the surface tension of gas bubbles, causing them to combine into larger bubbles in the stomach, which can then be passed more easily by means of belching. Dimethicone thus relieves flatulence. New gel is recommended in hyperacidity, GERD, gastroesophageal reflux disease, gastritis, flatulence, and as an adjuvant to NSAIDs. New gel is available as New Gel 200 ml suspension and New Gel tablets with delicious mint flavor. New gel is safe in pregnancy. New gel is sugar-free, hence safe for diabetics. For patients with symptomatic pain due to gastric and duodenal ulcer, Indus also presents New Gel O, the alginate raft-forming antacid with mucosal anesthetic agent oxytocin. Oxytocin is a potent, safe, local anesthetic agent that provides prolonged anesthesia of mucous membranes, thereby offering prompt and prolonged relief of pain. New Gel O is available in 200 ml suspension with mint flavor. New Gel and New Gel O. Raft formation reduces intensity and frequency of reflux attacks. Works in less than 5 minutes. Offers long-lasting effect up to 4 hours. Sugar-free, hence safe for diabetics. Delicious mint flavor improves patient compliance. We thank the entire medical fraternity for supporting Indus in our journey towards better healthcare.
Sit tight. Don't even take a bite. You don't want to miss the opportunity to win a prize in our Agpj Spotlight.
Sorry, could you stop Safari because Dr. Francis.
Today, I would like to highlight
Sorry,
our Agpj products available for mental disorders. Mental dis-
Right. We would just like we'd like to thank Indus Pharma for their support. As usual, we can always depend on Mr. Dea. And thanks always, sir. And now we can welcome back Dr. Frankson, who has had his heart-stopping moments and has managed to come right back with us. So onward, sir. Go ahead. Let's find back where you were.
Okay, man. I hope you are seeing me, my screen.
Yes.
Yeah, we're seeing the
You need
screen.
to
We're just
share
waiting for the
again.
presentation to open up on your side.
Pardon me?
We're seeing your screen, but the presentation hasn't opened as yet.
Oh, yeah. Same back, I have to do that one more time. And
Just make sure that you double click to seem like you're running it off a thumb drive, so it will take a little bit longer to load.
back to this one.
Just double click the presentation that you have there.
Is Dr. Frankson frozen again?
It appears so. Doctor, you there?
Dr. Frankson, are you hearing?
Seems like we lost him. We lost him again.
Yes, I'm speaking with him right now, and he's in another power cut. Mandeville is not serving him well today. Are you able to move from that site, Dr. Frankson?
Sit tight. Don't even take a bite. You don't want to miss the opportunity to win a prize in our Agpj Spotlight. Today, I would like to highlight our Agpj products available for mental disorders. Mental disorders are generally characterized by a combination of abnormal thoughts, perceptions, emotions, behaviors, and relationships with others. According to the World Health Organization on World Health Day 2021, close to 1 billion people have a mental disorder, and anyone, anywhere can be affected. People with severe mental disorders, such as schizophrenia, tend to die 10 to 20 years earlier than the general population, and 1 in every 100 deaths is by suicide. Now, there are 5 major classes of mental disorders: mood disorders, anxiety, eating disorders, dementia, and lastly, schizophrenia or psychotic disorders. Here are our Agpj products presently available to treat these mental disorders. Antipsychotics, both first and second generation, known as typical and atypical antipsychotics, which includes our apotrifluperazine, aporisperidone, and apoketiapine. Our selective serotonin reuptake inhibitors, apoparoxetine, apofluoxetine, and apocetrolene. Our benzodiazepines are apoalprazolam, apoclonazepam, apodiazepam, apolorazepam, apobromazepam, and apoclobazam. These medications are used to treat a variety of indications associated with mental disorders, such as schizophrenia, schizoaffective disorder, bipolar affective disorders, and major depressive disorders with psychotic features, and many others. How do antipsychotics work? First-generation antipsychotics inhibit dopaminergic neurotransmission in the brain. They are most effective when a 60 to 70% blockade of the D2 dopamine receptors is achieved. They also possess some noradrenergic, cholinergic, and histaminergic blocking action. Similarly, the second-generation antipsychotics inhibit the D2 receptors, but also possess serotonin receptor antagonistic action via the 5-HT2A serotonin receptor. The reduction of dopamine in the mesolimbic pathway of the brain causes the cessation of the positive symptoms associated with schizophrenia and schizoaffective disorders, namely hallucinations and delusions. Here are some benefits of using our antipsychotics. They are very lipophilic and are well absorbed. They undergo substantial pre-systemic elimination when administered orally. They also have a bioavailability of up to 70% and are highly bound to protein plasma and tissues, between 75 to 99%. They are extensively distributed and are primarily excreted hepatically. Let's review our SSRIs. SSRIs work by improving the transmission of messages between the neurons in the brain. They block the reuptake of serotonin and increase the amount available for transmission. They are called selective as they affect mainly serotonin and not other transmitters. They are highly protein bound and have long half-lives, greater than 10 hours, and are primarily metabolized hepatically. Some of the disorders that are apo-SSRIs, apoparoxetine, apofluoxetine, apocetrolene, are used to treat include major depressive disorder, general anxiety disorder, bipolar depression, panic disorders. We are now going to look at our apobenzodiazepines, apalprazolam, apoclonazepam, apodiazepam, apolorazepam, apoclobazam, and apobramazepam. These receive their name from their structure, a benzene ring bonded to a diazepine ring. Benzodiazepines are indicated for the treatment of anxiety, agitation, and insomnia. They are also indicated for use in spastic disorders, seizure disorders, and to induce amnesia. They worked by enhancing the effects of the neurotransmitter GABA. They induce hyperpolarization by opening chloride receptor channels, thereby increasing the intracellular concentration of chloride. This presents as a relief of anxiety and overall improvement in mood. The benzodiazepines are lipid soluble and have a high volume of distribution in the body. As a result, higher concentrations of the drug can be found in the tissues rather than in the blood. They are primarily metabolized by the liver and excreted in the urine. They have a rapid onset of action and long half-lives. Benzodiazepines should be used with caution in the elderly, smokers, and individuals with liver impairment due to disease or damage. Use of various treatment options is guided by the phase of illness in which the patient presents to the clinician and past treatment history.
Why should you prescribe the APO? Well, 1. You're assured of high quality. Our products are formulated to contain the same active ingredients and to produce the same beneficial effects as the originator they replicate. 2. You get affordability. Our products are at a price point that patients can afford. 3. Accessibility. Our products are well distributed in all pharmacies island-wide. 4. Our therapeutic range. We have a wide range of products in numerous strengths and forms. So please remember to add the APO prefix to ensure your patients receive a high-quality, affordable pharmaceutical option. Have an apotastic day.
Well, just like to thank our sponsor, Agpj, for sharing with us your mental health supportive medications and your teaching with us of how they work. So we thank Agpj for their sponsorship, and we are rejoined again by Dr. Franson, who is working with the world of technology and is actually presenting from, I believe, his cell phone. I think he's going to email, if possible, his slides to Tafari, and he will run them. If you can, Dr. Franson, he will run them while you speak. If not, it's over to you. One way or the other, we are running the ship today. We are not running aboard any sandbars. Forward. Go ahead, sir.
Yes. Okay. Yes. So I really apologize for this, and I hope that it will be cleared up soon. But we were talking a little bit about ethics, morality, and now we're going to add the law as a quick one, just a skeleton of it. There are 4 major categories for ethics. There's descriptive ethics, that's when you're comparing how people do things in their culture versus your culture when it comes to, for example, in certain Western European countries, euthanasia is permitted, whereas over in our side of the world, everybody would frown on euthanasia, and so on and so forth. So that's more descriptive, and it affects even what we're talking about today, healthcare, because the world is divided, and there's much to be compared and to learn from and to correct. Then there's normative ethics. And with normative ethics, it's the one we'd usually love to do a lot, which is prescribe rules, and generally and also specifically for certain situations. And of course, there's meta-ethics, which is where the philosophers take the time to do look at the meaning of the word just, the meaning of the word good, the meaning of the word right, etc. Epistemological approaches. And one that is a more recent development in ethics is arithmetic ethics. After you've gone through whatever you've done, what did you end up being? Did you end up being a better person? Did you end up being a just person? Did you end up being a person who is more respectful of people's autonomy, etc., etc. Resultant virtues, in other words. So you can see it tends to be something where the end result is what is more important. And for that, what you have is what we call a teleological approach, where the end almost justifies the mean. Well, you go to that extreme, one branch of it is called utilitarianism. And then that's versus a deontological or duty-based approach, where we get our duties of care, etc., which ties in a lot with what we're going to do today too. And a relativistic approach is also coming up more these days, the last decade or so, where it's cultural relativism is what is the thing. You have your truth, I have my truth. You look at life by your way, I look at life my way. We're both right. Let's press on. And you could do that from a group level, a cultural level, or you could do it on a personal level, where it's what we refer to as moral subjectivism. And some of these things, all of these four categories, sometimes are legal as well, but some of them are not legal at the time, because sometimes the law needs to catch up. The law has been outgrown. That's why we need to change our medical acts where necessary at points, in certain clauses in it from time to time, because culture moves on. And the same with our health services delivery. There are certain things where culture moves on. And on a personal level, we're dealing with smaller groups of people, where we look at our personal preferences too. Now, the law itself is very much one of those things that helps us to have good relationships, just like ethics and theology and morality and so. But what the law is these codes that have gone to a level where society galvanized around them and made them into codes and that are enforceable by some authority, whether it is by the medical council of your country, or whether it is by some educational council or some policing or so on. They're really trying to guide our behaviors in society and various relationships that we have. And in health, we have many relationships that we go through each day, from the delivery or from the advertisements that you've been watching, etc. There are all kinds of relationships that we have. And, some are ethical, while some are unethical. So sometimes we have unethical law, and we have to then try to find ways to use society properly to change those. And they could be common laws, civil laws, or they could be criminal laws if the act is so horrendous that society balks at it and says, not only should we repair the breach, but we should actually now send a strong message by having punitive measures attached to it whenever there is damages to the relationship, such as stealing, for example. You don't just return the thing, you probably should also get some punishment for that, and so forth, to send a message that that's something that you really should not try again. Many people don't learn it though. The minimum moral standard of a society is the law, not ethics. Alexander Solzhenitsyn, born in 1918 and died in 2008. Some of us will remember him, the great philosopher, historian, and so from Russia, who helped us to understand the Gulag system in Russia and the CCP.
And his saying is, if all you're doing is keeping the law, you're actually operating at the lowest moral standard that there is in society. When we're doing ethics, we have a model for making moral decisions, and one is gather the facts, and the other one is determine the ethical issues. Usually they revolve around things like justice, or fairness, equity, accessibility, and so forth. Beneficence, what's good for you, what's wholesome, what will help you to become a more fulsome person, morally, etc., relationship-wise, and so forth. And then there's non-maleficence, which is the famous Roman primum non nocere, first do no harm, a virtual impossibility in healthcare. You will do a little harm, but what you do is you engage in balancing risks versus benefits, and you move on with the things, whether you take either a deontological or relativistic or a teleological approach. And there is the famous autonomy. The actually proper phrase is not autonomy, it's respect for autonomy. But sometimes lazily we just say autonomy. Respect for people to get their consent, to keep confidentiality, etc., and so forth. And we have the Data Protection Act is wrestling with a lot of that, and is trying to help us. And some aspects of it will be found out to be unethical, and therefore will need to be corrected. But it will only happen after we put it, let the rubber hit the road. And many aspects will be found to be quite ethical. Some aspects will be found to be unethical because it might tend towards fragmenting information, especially when specialists can only put in just the areas that they work in. Does that really serve the holistic care of the patient? All of those things will have to be wrestled with as we put those things into practice. And we move on to determining what virtues or principles have a bearing on the case. Once we do that, then we list alternatives. And then you compare the alternatives with the virtues or principles. And number 6, you consider the consequences. And then you make a decision, which is one of the reasons why excuse me a little bit. Excuse me a little bit. I tried to shut down this alarm.
Doc, we are with you. We are with you. Just encouraging you. Do your best here. We are with you. Stand mute again. God is in charge. He's with us. Do your best. Lots of trials and tribulations, but we persevere. Your presentation is certainly enlightening. Interesting. Ready for us? Okay. Good to see a smile on your face, Doc, as you go through these terrible trials, trying to present to us this morning on the ethical conundrums which we are facing in this time. Doc is walking, obviously. You can talk to us. You're going to a different site.
Trying to escape the alarm by going somewhere else. So put some distance, then hopefully we
Close
won't
the
hear
door
the
behind
annoying
you to
alarm.
lock out the sound. You can close the wherever you're walking.
So what is the, may I continue?
If you, as you wish.
Okay, I think I've distanced myself from that crazy alarm. Yes, well, I'm in beautiful Mandeville here, but struggling Jamaica. Okay, so the way forward would be.
Okay, sir, so you just finished talking with us a bit about the Data Protection Act and the fact that some aspects might be unethical.
When we are looking at issues of access versus issues of quality in our constrained environment. Our context in our countries, a lot of our
The volume needs to be higher.
Quite constrained environments, and this is a very timely topic as far as addressing it is concerned. And there are really three kinds of countries when every country has constraints. And there are really three kinds of those constraints. And there are countries that have high expenditure health economies, such as our neighboring United States of America and Canada, and some Western European countries. And those countries have their own challenges in that they have the resources, but they struggle sometimes with the political will to put things in place that will cause access and affordable care. We only need to remember the struggles that the Obamacare had and the many trials to try to remove that law by the lawmakers. And there's still threats being made in political campaigns regarding that. However, they have a lot of resources, they have a lot of leeway, and once they're able to put that in place, what they put in place was not a perfect system, but neither is the one in Europe, even though it has certain distinct advantages over those in, say, the United States. And that's one kind of situation. But what that kind of healthcare really has done is it's coming from a very hospital-centered and mega health system-centered kind of care. And it has encouraged a reductionist approach where modern ways of treatment were considered to go and specialize. And the more you specialized, the more care became fragmented for people, and the more out-of-pocket payments when they were unregulated would do harm to families and their economics. Or if you were blessed to have insurance programs, they were usually catastrophic care kinds of insurance programs, and that too had its limitations because it gave glorious care once you made it to whatever portal you would receive that. You would get wonderful, best, top of the line care. But many of the things could have been prevented. Many of the things could have been seen earlier, etc. And it never easily lent itself to that. So that is being corrected in such situations. You have the next kinds of health reform that is in some countries is rapid growth health economies. We kind of fall somewhere near there in the Caribbean because we have countries like Thailand and Taiwan and so forth that have rapidly grown, South Korea and so forth. They have rapidly grown. It's amazing the kinds of things that they have been able to put in place. And with that rapid growth has been a huge amount of money that has attracted things that actually just followed some of the mistakes of the countries that had the high expenditure health economies. However, with concerted effort, they have been able to improve their primary healthcare structure and improve their
Okay, we seem to have lost Dr. Franson yet again. And I want to say to Dr. Franson, thank you for this very, very, the effort has been absolutely courageous and just so very, very here for us. I'm going to ask if we can just go ahead with Dr. Wright. Start, Dr. Wright.
I'm back.
You're back? You're back.
Sorry.
Okay.
Yes.
All right.
So
Okay, then. Go ahead, sir, because I was just thanking you for your courage. Thanking you for your courage. Go ahead. We're not hearing you, Dr. Franson.
For example, those low expenditure, low growth health economies, across several parts of Africa, and it's a dynamic process. Some countries are
Dr. Franson, I'm going to, I know you have, your problem is that you are unsure that you can come back on later on because you have another function. So you are trying to complete your presentation. Are you back with us at all? If the answer is no, I think we do have to move on to Dr. Wright and see if you can at all come back afterwards. And you can try and see if you can sort out your situation a little bit more. We thank you for this effort, and we are going to hand over to Dr. Wright now. Thank you, sir. Now I have to introduce Dr. Wright to you all. So it is my pleasure this morning to say a big welcome to Dr. Earl G. Wright, who is well known to us in Jamaica, as he has served us very, very well as a consultant psychiatrist, physician, and public health specialist. He sits on the Medical Council of Jamaica, and it is indeed his passion to get mental health to the forefront of medicine and to integrate mental health into all other areas of medicine. Indeed, it is this passion which has resulted in the mandatory 2 extra additional hours of mental health CME each year, which we have to obtain in order to get our practicing, which we have to attend in order to obtain our practicing certificates. So Dr. Wright, your passion has resulted in upgrading our compulsory hours to bring us to our certification. So we thank you for that. It is indeed needed. Dr. Wright also chairs the Mental Health Technical Advisory Group on the Medical Council of Jamaica and is a past president of the Jamaica Psychiatric Association and chairman of the Mental Health and Homelessness Task Force. Dr. Wright has also served as a past director of Mental Health and Substance Abuse Services in the Ministry of Health, and also has previously held a similar position of Director of Community Mental Health Services for the state of New York. I think this was in the Manhattan borough. He is a skilled and highly experienced physician. Like Dr. Franson, who we were listening to before, Dr. Wright is a Kingston College graduate and a graduate of the University of the West Indies, and completed his postgraduate medical education at Harlem Hospital, Columbia University, New York. While there, he did his psychiatry residency and obtained his master's degree in public health. He specialized in community mental health, which is why, of course, we see so much of Dr. Wright in our communities across Jamaica. He has served as a medical director for Upper Manhattan Mental Health Center. So his experience is wide, vast. Dr. Wright returned to Jamaica in 1980, and as Director of Mental Health and Substance Abuse Services in the Ministry of Health, he has guided this task that he has had of integrating mental health with general healthcare services in the government health system. There are two questions he wants us all to ask every day with every patient that we see. And these are, during the past month, to your patient, have you enjoyed your life? If the answer to that is no, or then have you been feeling sad? Dr. Wright advises that this is what we need. Each of us does these two questions to make sure we are completing what we need to know about our patient's health at each point in time we see them. So Dr. Wright will speak with us today on, I think let me have it somewhere, on mental health and wellness and emotional intelligence. Dr. Wright, over to you, sir.
Thank you, Dr. Brown Morgan, on that introduction. It's great to be here to talk to you about mental health. As you say, it's my passion. Always wanted to reposition mental health in the mind and in the delivery of service in Jamaica. So I'm hoping we are moving towards that. And I'm one of those that's been thought COVID-19 been very useful because it has brought mental health to the fore. Everybody know that they have mental health to take care of, like they have physical health to take care of. So let me start. I'm going to be talking about mental health, focusing on stress. And we always start with brain development and behavior because mental health is about brain health. And our behaviors come from our brain. And mental health and physical health you cannot separate. And then I'll talk about emotional intelligence a bit and stress. All right. A lot of times when I talk with doctors and I talk about mental health, they're not really talking about mental health. They're talking about psychiatry. And in Jamaica, most of the time they move to one disorder, schizophrenia. And that's why I think today we need to focus on mental health and mental wellness. And the definition of psychiatry is a medical specialty, as you know, diagnosing and preventing mental health disorders and practiced by a psychiatrist. We're having more and more psychiatrists in Jamaica, but we need to focus more on mental health. That refers to all our patients, refers to personal patients' overall emotional and psychological well-being, and it includes the ability to manage one's emotions, thoughts, and behaviors in a healthy way. And when I see doctors fighting in the public and on videos, I think mental health and managing our emotions are very important. When we think of the levels of violence in Jamaica, I think we as physicians also need to focus on mental health when we know that we are having nearly half of the population having what we call personality disorders. Then we know the country as a whole is running into problems, and we as physicians have a responsibility, since we have the knowledge, to focus on that. But in order to focus on that, we need also to focus on ourselves, and therefore the mental wellness, the ability for each physician, each of us, to lead a fulfilling and satisfying life. And it encompasses various segments of mental health, such as emotional well-being, cognitive well-being, and social well-being. And as you know, the Ministry of Health has added wellness to their portfolio. So the different aspects of mental health, the absence of mental illness or mental disorder, positive mental health, mental well-being. And there's a subjective part of mental health, feeling good. Each individual should feel good about themselves, be satisfied with life. And in some of the Constitution, you have to strive towards a sense of happiness. Prefer to call it well-being. Also, you should have psychological well-being, autonomy, should accept yourself, acceptance, self-acceptance, personal growth, should have a purpose in life, should be able to master your environment and the stressors that come on an ongoing basis, and positive relationships with others. If you're always fighting with others, if you're always in disagreement with others, then your mental health is not as good as it is supposed to be. And then the absence of behavioral problems, the absence of emotional problems, self-esteem, good peer relationships, should also, the emotional intelligence part, emotional awareness, know how you feel, respect for your own and others' emotional state, be able to manage your emotions, the capacity to integrate thinking and feeling, and the capacity to communicate emotional information. A lot of times in Jamaica, when you ask individual that's out of their comfort zone, they tell you they feel away. Each individual should be able to tell you how they are really feeling, and we'll touch on that a bit later. I want to ask you now, I want you to go into yourself and tell me how you're feeling. You don't have to tell me, you just have to tell yourself. Do you feel optimistic about the future? Is that all the time, often, some of the time, rarely, or none of the time? How do you really feel most of the time? Relaxed, Do you always feel relaxed? Do you feel it rarely or none of the time? Close to other people. Do you often feel close to other people? Do you feel close to other people all the time or none of the time? Useful. Interested in other people. Feel good about yourself. Confident. Cheerful. Loved. Are you able to think clearly all the time? Able to make decisions, make up your mind about things? Interested in new things? Dealing with problems well? And have energy to spare, not tired all the time. If your answer to all of those are all the time, then you're doing very well. If it's rarely, then you're doing not so well. But you have to look into yourself and be honest about how you're feeling. On a scale of 1 to 10, where 10 is your best and 1 is your worst, how are you really feeling? Or you need to think about that and look into that. And if it's not as good as you would like it to be, we need to find ways of making it better. So it all starts with the brain. The mind and the mental functions emerge from the biological functions of the brain. The road to mental health is therefore determined by the brain's development. And mental health is, if your brain is not functioning well, then your mental health is not going to be as good as it should be. And it all starts early in life. And as we know, early childhood, a critical period of an individual's wiring, brain wiring, life, the trajectory you are going to take starts between age 0 and 6. Critical period of wiring and sculpturing of the genes, how the exposure of your genes to the environment and whether genes are turned off or turned on. And this is called a refinement. And if we look at this, you'll see the sensitive periods. I know some of you might have seen this already. Preschool years are the most important years. And as you know how vision, the ophthalmologist, hearing, you see by age 4, the hardwiring take place. Sorry about, let me go back. The hardwiring take place. Yes. The vision, as you see, the hardwiring, hearing. And then very early in life, you had habitual ways of responding, your biases, emotional control. If that doesn't take place early in the first 4 years, 5 years of life, and most of it occurs during the first 3 years, then you're always gonna have problems. And we're really talking about the amygdala. If the amygdala is exposed to external violence, trauma, adverse childhood events, then that amygdala is not going to develop in a healthy way. It's going to be hyperactive or underactive. Development in nonlinear, in warm, responsive, careful environment, supportive brain development take place, and the brain determines the emotional and social responsiveness in adulthood. So if in the early years, in the first 3 years of life, the amygdala is exposed to adverse events, traumas, abuse, corporal punishment, etc., then that amygdala is going to see the world as a hostile place and therefore gonna have problems. Stressful and traumatic events undermine development of stress. Therefore, we run into problems, right? Stressful or traumatic experiences undermine development. So if you have a child that's always exposed to gunfire, exposed to their parents quarreling, then that's gonna cause problems, lower the threshold for activation of the stress response. So your stress response has been determined very early in life. This is the brain at birth, as you know, 6 years and 14 years. You notice the difference between where the pruning, apoptosis takes place here. So I would like to see my brain now, not much gonna be there. But there's always hope. This is another view, same thing. Binocular vision, emotional control by age 5, most of it has taken place. Habitual responding, and then later on, the socialization, languages, etc. This is another important thing, that children, infants need face-to-face communication. The eye-to-eye orientation, the vocalization, the hand gestures, etc., is absolutely important. More and more, we are seeing children sitting in front of screens, and that is not recommended. The Pediatric Association worldwide has their various number of hours. But what is important is the direct attention from the adult caregiver to the child so that modeling can take place. That is not done, then the child's brain is going to develop not as in a healthy way. Childhood adversity should be minimized. Efforts to address all the things that we know to diminish toxic stress, because if there is toxic stress, you're going to have epigenetic modification and disruptive architecture of the brain. And I dare to say, in keeping with Hicklin's research, where 40% of the Jamaican population brain has not developed as it should, and therefore we see a high incidence of personality disorders, antisocial disorders, borderline personalities, etc., leading to the lack of productivity and the violence, and also the development of non-communicable diseases. Or it's well documented that if there is toxic stress, there is a direction, there is a trajectory towards the development of non-communicable diseases. And that is because of what we call behavioral allostasis, where the individual tries to get back to normal allostasis. And in order to do that, in an effort to do that, you have the binge drinking, the promiscuity, the comfort food eating so that they can feel better quickly. And this leads eventually to unhealthy habits. A brain, PET scan of a brain of somebody who's been abused here, and you see in normal brain, you see the activity being all in the midbrain and in the prefrontal cortex. In the abused brain, you see a lot of inactive areas. And this is what occurs. Might not be to that extent in many of our children, but if there is a high incidence of adverse childhood events, then you move from this area towards this area. So it's very important that we put in the necessary programs, etc., to improve parental skills so that you can move away from this adverse childhood events causing the inappropriate architectural development of the brain to the development of healthy brain, especially the midbrain and the amygdala. But if we look on where money is spent, most money is spent on the elderly. And very little, not as much money. And this is the same thing in Jamaica as in other countries. And I was saying to myself for the day that a lot of the drugs from the NHF, you have, it's been spent on cancers and the elderly, but drugs like for the young people, the concerta, etc., is not being subsidized as well as it should. And this is the response of the brain. In the early years, you can get much change. You notice the large change that you get with effort between age up to age 60, and that continues until in mid-20s. After that, it becomes the effort for change becomes less and less. So we're talking about repetition and pattern sensory experience results in the neural organization of the brain and the capacity to moderate emotion, to manage your emotions. When somebody do you something and you get annoyed, you can manage it. Develops with repetition and it also develops in warm, secure, caring environment. If the environment is not warm, secure, and caring, then it becomes very difficult to develop those managed emotions as well as you should. So the responsibility of the health sector, promotion of good health, including mental health, and you see well-being as part of the definition of WHO health, mental health, etc. So it's important that we do what is necessary for the well-being, including physical and mental health. And therefore, the early recognition and effective treatment of mental disorders and the promotion of mental health. Just gonna run through these quickly. We have managed to get rid of most of these problems affecting mental health. The malnutrition, we have overnutrition now. Some of these things, chronic maternal stress, delivery complications, prematurity, low birth weight, head injuries, post-traumatic stress, we still have a lot here. Exposure to toxins, we have done very well with that. Criminal father, that's part of it. I'm not sure what we can do about that. And multiple breaks in caregivers. Lack of consistent caregiving is also part of the problems. Maternal rejection, maternal depression, which is very important that we as physicians should screen for depression so that we can detect maternal depression early and treat it effectively. Parental substance abuse, child neglect, parental discord, and ineffective discipline all add to poor mental health. And this is just a picture of this screening, the sources of resilience, the buffers for stress, and what needs to be done. Impaired with social structures, the outcome of life-altering trajectory courses, that if you have alcohol abuse, tobacco, substance abuse, promiscuity, etc., then you need to look back and see what has happened early in that individual's life so that has caused them to have these problems, and these eventually gonna lead to non-communicable diseases, and there are economic and intergenerational problems. So the importance of screening for depression, and the Ministry of Health has it in their documents that you should ask these two questions. During the past month, have you been bothered by feeling down, depressed, or hopeless? During the past month, have you been bothered by having little pleasure or interest in doing things? And I'm always impressed when I go abroad and I do a medical, regardless of whether I see the surgeon or the gastroenterologist, they ask these two questions. And you're in where I go, you get asked twice. You are asked by the nurse who screen you for depression, and you are asked by the physician. And if the answer to either of those is a yes, then you need to go and ask the 9th question. The 8 more, any weight change, putting on weight gain or weight loss, sleep disturbance, psychomotor problems, can't stay still, psychomotor agitation or retardation, fatigue or lack of energy, excessive guilt, feelings of worthlessness, diminished concentration, and recurrent thoughts of death and suicide. And it is my opinion that all physicians, especially all general practitioners, should be able to treat clinical depression. When you refer to the psychiatrist, when patient is suicidal, when you're not sure about the diagnosis, or when it's a severe major depressive disorder. But most patients with depressions are going to come first to the primary healthcare physicians, the general practitioners, and they should be able to screen for depression and start treatment. Just like how every time a patient comes to you, you do your blood pressure or you do your check for glucose level, you should also screen for depression. All right, gonna switch to emotional intelligence and stress. And I recommend highly this book, Daniel Goleman, the groundbreaking book on emotional intelligence, Why It Matters More Than IQ. And most of you remember individuals who you were at school with that was much brighter than you were, got always first and second. But if you look back on where they are now, a lot of them are not where you would like them to be, because the emotional intelligence of those individuals were not as good as their IQ. If you look at the whole person, you have IQ, EQ, emotional intelligence, and their personality. The personality traits, the trait that define us, and I'm not going to go into that. Each of us are either introverts, to some extent, extroverts, conservers, pragmatists, originators. Some of us are obsessive compulsive, etc. And there are a number of personality traits. Emotional intelligence is the ability to know and manage oneself, with an awareness of the ability to manage one relationship with others. And the more emotional intelligent a doctor is, the more they will be better able to manage and relate to their patients. Always ask this question: do you think that your decisions are always logical, or are they always colored by your emotions? What do you think? We can talk about that later. And this is just a graphic of where the brain, a lot of impulses enter the brain, where you feel and where you rational. Executive brain is over there. So emotional intelligence usually thought it's comprised of self-awareness, self-management, social awareness, and relationship management. You're gonna self-awareness. Each individual should be aware of how they are feeling at any time. I want you to go inside yourself and think of a time when you are not feeling as good as you should. When if somebody bad drive you, or something happened at home, or you met in an accident or something like that, you had a puncture on your way to work, and how this affected your work, how this affected how you manage things. What are the feelings? How did it affect your decision making, your communication, managing others, managing conflicts, or your teamwork? When you really go inside yourself and think of a time when something bad happened to you and how you felt. Think of the worst thing that happened to you and how you felt and how it affected your life. I want you to switch now. Think of a time when something good happened to you and you felt good. And how did you work? How did you do things at work? How did you talk to other people? How did you work with others? Was there a difference? The point is that you should always be aware of how you are feeling. So we're talking about just being aware of yourself, the ability to accurately perceive your emotions and stay aware of them as they happen. This includes keeping on top of how you tend to respond to specific situations and certain people. When you are feeling angry, each of us have a specific way of reacting to severe stress. Some of us get angry, some of us withdraw, some of us different ways. So you as an individual needs to be aware of how you react under stressful situation, and so that you can manage it more effectively. Are you aware of your day-to-day feelings and factor them into your day-to-day activities? Right now, how are you feeling today? Are you able to comfortably say that? We ask one another, how are we feeling all the time? But most time we get to perform the usual answer, okay. We don't want to hear how the other person feels, and they don't really want to tell us. But it's important that we as an individual ask how you're feeling and know how we are feeling on a day-to-day basis. So, again, we said what role your emotions play in your interaction. How is it influencing your back and forth? How does anger play a role in this? Do you get angry? And are you able to manage your anger in your interactions with others, regardless of how much trigger that person have done to you? How much does fear play a role in your interaction? Do you freeze? Do you can't think when you are under stress? Do you sweat? Do you get tunnel vision? Do you get palpitations? Do you shake? Do your thoughts race? Do you feel numb? Do you get dry throat and can't? And there are a number of different ways each of us will react to a stressful situation. But it's important that each of us recognize how we react to a stressor and find ways of managing it effectively. So we're talking about perceiving the emotions, the ability to decipher emotions in others, in faces, pictures, and in our patient, and use emotions to harness emotion, facilitate the cognitive activities such as thinking and problem solving. And as I said, a lot of times when we ask individuals how they are feeling, they tell you they are feeling away, but there are various families of feelings, and they can be broken down into a wide range, and the reaction to each of them is different. So if you just lump them into feeling away or feeling uncomfortable, your reaction might not be appropriate. Fear, there is horror and alarm, shock, fear, fright, panic, hysteria, and then you move to the anxiety, the worry, the distress, and the dread, all different. A lot of times you see children, they will get angry and hit the wall when they're doing homework or something, when what they are feeling is frustration. But a lot of children mix up frustration and anger. And when you are frustrated, you should go and take a pause or ask for help, while the hitting of the wall is the mixing up of anger and frustration. So they act inappropriately. So it's very important not only to have feelings, but to recognize the feelings and put a name to it. So we talk about managing emotions, the ability to regulate emotion in both ourselves and others, talk down of other people so that they can bring down their emotions. Emotionally intelligent people can harness emotion, even negative ones, to achieve their intended goals. So if we talk about self-management, emotional self-control, keep disruptive emotions and impulses in check. Adaptability, flexible in handling change. Achievement-oriented, striving to improve or meet a standard of excellence. That's the conscious goal. And reframing, positive outlook. There's nothing you can't reframe and have a persistent in pursuing goal despite obstacles and setback. Self-control, and most of us have done this very well, delaying immediate gratification, putting off immediate pleasure so you can get greater pleasure later on. Openness, being open to other people's perspective. Your way is not the only way. There are other perspectives that are just as right as yours. Adaptability. Also self-management, initiative, and reframing to having an optimistic outlook. And we touched on this, social awareness, the ability to pick up on emotions in other people and understand, try to understand what is going on with them. We as doctors have learned over the years to develop the empathy and social awareness, perceiving what other people are thinking, even if you do not feel the same way. And mostly important is sensing other people's feelings and perspective and taking an active interest, underlying active interest in their concerns, putting yourself in their shoes. When did somebody come in a bad mood and want to tear up the place, try to understand what's been going on with them. When around people, do you spend extra time observing, asking, listening? Do you focus on your thoughts and on the next question or on the other person's perspective and try not to let your thoughts and feelings disturb the interaction? Very important that we develop the art of listening to the patient and to others. When people build their emotional intelligence, they perform better, treat one another better, and get more out of going to work. It creates an environment where everybody wins. And remember, emotions always serve a purpose because they are your reaction to your past experience and always come from somewhere. When you meet a person and your spirit don't take them, you just don't like them, it always come from your past experience. And it's usually helpful to go back in your life and find out where that come from. Understanding why the current circumstances generate these feelings is important, so that the next time those feelings are generated, you can understand them better. Very important to be aware of your feelings, to know of your what we call your allostatic load. Stress up to a point increases focus, creativity, and efficiency. Stress hormones improve performance, but impairs it when the stress becomes constant or too much. So it's important to learn when stress is beginning to hinder rather than help your work, so that you can do something. You can dial down your stress so you can return to peak effectiveness. Again, how are you feeling today? How's your attention span? I know it's been a long morning, so I recognize that your attention span must be going down. Take a note of your mood. How are you feeling? Take a note of your stamina. And it's always important to listen to your body and your thought patterns. But chronic stress is the hallmark of burnout. And I'm not going to talk about burnout specifically today because there's a conference coming up where the Medical Council of Jamaica are going to be doing their conference on ethics and mental health, and mental health portion will focus to a large extent on burnout. That will be, I think it's the 28th of January, the last Sunday in January. But chronic stress, a hallmark of burnout, trigger a cascade of neurobiological changes that contribute to the debilitating symptoms of burnout. The core symptoms of burnout: emotional exhaustion, cynicism, professional inefficacy. Emotional exhaustion manifests as feelings overwhelmed of fatigue. And fatigue is the number one thing that people, when they're starting to move into mental health problems, start feeling. Fatigue and problem with sleeping. Feel depleted, detached. They develop cynicism, characterized by a negative, jaded attitude towards work that can erode empathy and compassion, the very cornerstone of our medical care. And this perception of being unable to meet one's professional standards can lead to being guilty, feeling of inadequacy, and decreased job satisfaction. So what's going to be important is to manage burnout is to start at the beginning and manage stress effectively. But I always go back to the early years that in Jamaica, we need also to start with decreasing our adverse childhood events and toxic stress, because doctors are reflective of their community. And therefore, if 40% of the community has personality disorders, you're going to find that doctors will also have personality disorders. So we're talking about managing the stresses of life and the fight or flight. In our situation now, where we have fight or flight response, there are few situations in life where modern work life, where fight or flight response is useful. Most situations benefit from calm, rational, controlled, sensitive approach, therefore managing this instinctive response. Therefore, if you're going to have what we call emotional hijacking, where the midbrain takes over and the emotion and the executive brain is not able to manage your emotions, then we are going to be in problems. Fight or flight hormonal response, mainly cortisol and adrenaline, is a normal part of everyday life. Frustrations, interruptions, challenges, but we need to manage them on a daily basis so that we lower our allostatic load that we carry around with us. And if we talk about managing stress, you must feel threatened by the situation and must feel that you don't have the capabilities or the resources to meet the threat. If you feel you have the resources, whatever they are, and you are not threatened by the situation, then most of the time the situation shouldn't be stressful. Not going to go too much into this. The signs of stress, anxiety, the gastrointestinal, depression, fatigue, headache, sleeping problems, etc. And the neurobiology, the secretion of corticotropin releasing hormone in the brain to the hypothalamus, to the anterior pituitary gland, to the adrenal gland, that's gonna secrete cortisol. And the cortisol is one of the major culprits that's gonna cause non-communicable diseases and alter the body. Not gonna go much, you all know this, corticotropin releasing and all the effects. And this is just showing what post-traumatic stress disorder causes: dysregulation of glucocorticoid, and the feedback loop changes. So the negative loop that goes back to the brain is changed. And this also happens with depression. That's why you find that individuals, as they get older, especially individuals 50 and above, they don't need a stressor to cause their depression, because the feedback loop is already shifted and the cortisol level in their blood is already increased because of the long episodes of depression. Cortisol again to the negative feedback on the pituitary, that's gonna cause the increase in non-communicable disease and some behavioral problems, mental health problems later on. It's just showing you long-term effect of cortisol, the heart disease. You have a higher incidence, prevalence of myocardial infarction because cortisol gonna increase atherosclerosis. And if so, stress, long-term stress is a risk factor for heart disease. The immune system is weakened, anxiety, depression, headaches. There's a high level of serotonin in the digestive tract, so you're gonna have problems there. Cortisol predisposes you to diabetes, and noradrenaline predisposes you to high blood pressure. So there is a direct effect between stress and many of the physical and mental disorders. So what can you do? Because I'm not going to only talk about all the things that you get, but we need also to think about some of the things that we can do. And we as doctors are not very good at taking care of ourselves. I see that all the time. We are very good at stating what needs to be done, but to plan it to ourselves is sometimes a major problem. So we're talking about taking a walk, and we'll talk more, the usual deep breathing, exercise, dancing, being with your supportive system, singing, journaling, smiling. When you smile, you secrete some of the endorphins and other chemicals in your brain. And this I know is very strong in Jamaica, the prayer. So I'm going to do some truism now. Struggle is good. Never say I can't take anymore. Say bring it on. Don't complain. Complaining is the biggest waste of time there is. Either do something about it, or if you can't, stay quiet. Spend time with people you love, positive people. If you are around people that are negative, whoever you are around, you're going to take on some of their attributes because we reflect our environment. The spindle cells in the insula reflects our environment, so that changes over time. You become a part of your environment. So it's important that you make a special effort to have positive people around you and people you love. Don't start relationship you are not in love, because you might run into problems later on. You might either like someone and think we might give it a shot. Not a good idea. You're either in love or you're not. Don't fool yourself. It's not fair to you or the other person. Exercise daily, and that will come up again and again. Keep a journal. Be grateful. Reframe. And I not only keep a journal, but keep a gratitude journal. If you focus on the gratitude, then your thinking will change. And don't care about what people, sometimes you have to care about you and what you are about. At some point, everybody, bar none, gonna experience a stressful event or a situation that's gonna overwhelm their coping mechanism. Therefore, it's gonna be important to put in your stress management techniques so that you can get through this period. And we've all been through a very fearful situation where COVID, where there was fear and uncertainty, health concern, there was a lot of social isolation and loneliness, disruptions in daily life. Most of us will have known somebody that we lost, loss of grief and loss, and also some financial strain. So during this time, there was a heightened stress level. And because of that, we are seeing more anxiety, depression, etc. in the society. And therefore, the allostatic load of all of us have increased because of COVID if we haven't been doing something consciously to bring it down. All right. So it's important that on a daily basis, we take time to reflect. take some time on a daily basis to look at ourselves and see where we're going. Keep a stress journal and prioritize and list our stressors. I always recommend that you write down on a 2-week basis your stressors, and then after that time, you relook at them and reset your priorities. And you'll find that most of the time, you will find that you can go back and wipe off some of the things that you are doing that's not helpful to you or helpful to other people. You redo your prioritize, you reprioritize your list of things that are making you uncomfortable and giving you stress. Restructure your priorities. It's important that each of us do that from time to time. And we come into the end of the year now, we in December. So it's a time when we need to look back on 2023 and start preparing, restructuring our priorities for 2024 so we can live a better life in 2024. Always like to look at this. The Serenity Prayer gives this. Things I can't control. Can't control the past. Can't control other people's action. Can't control what other people think of me. You can't manage how people treat you. You can't control what other people, choices other people make. You might try to control them, but you can't control it. They are going to make the choices. The other people's happiness. So things you can't control, you write them off. You can't do anything about, and you accept it. But your attitude, you can control. Your actions, you can control. Your choices, your thoughts, you can control how you think. You can control your happiness. You can reframe anything to make yourself feel better. You can control your boundaries, your time, and your reaction. These are all things that you can consciously take control of. So restructuring your priorities, you need to be true to yourself. Don't be dishonest with yourself and treat others. This is usual Christian principle, treat others as you'd like to be treated. And if you put that at the forefront, then you will be well on your way. Take responsibility for your action. And we said, not only you do a journal, but you do a gratitude journal. Learn from your mistakes, and we should never stop learning. Be open-minded, willing to change your perspective. Your way is not always the right way. Other people's ways are just as relevant as yours. And I always emphasize, take care of your physical and mental health. That's why you need to do things to manage your mental health on a daily basis. Set goals and work towards them consistently. Embrace challenges and push yourself towards your outside of your comfort zone. If you don't push yourself outside of your comfort zone and take risks, then you are not going to be as successful as you ought to be. Cultivate meaningful relationship with friends and family. Nobody can be alone. It's very well documented that if you don't have a social network, if you are isolated, your lifespan decreases. Strive to balance in work life. You have to take care of yourself, so you have to strive to balance your life, work-life aspect. Live with intention, and purpose. Be kind and generous to others. The more you give, the better you feel. We are wired so that when we are generous to others, chemicals are released, neurochemicals are released in our brain, that help us to feel better. Don't be afraid to ask for help or support when needed. And this is especially important in our medical community, where a lot of doctors, when they're having mental health problems, when they're not sleeping, when they are depressed, when they are unhappy, they are very reluctant to ask for help. And a lot of doctors self-medicate, either with the anxiolytics or with alcohol. Celebrate your success and accomplishment. Give back to your community, be patient and persistent. Give something to a social stranger, because that's gonna make you feel better. Educate yourself. Research is what you're experiencing. Ask yourself with the knowledge and resources to tackle the problem head on. And always remember that not everybody is as lucky or as competent as you are. I remember in my day, we used to look at Garfield Sobers, a cricketer, and he used to wonder how he could, where everybody couldn't hit six as him. And many of us with our abilities, we take it as second nature, and we can't understand why other people can do things as easily as we do. Comes back again to empathy. 3 things we need to adapt. 1, 3 hobbies that you enjoy. 1 to keep you creative, 1 to keep you in shape, and 1 to make money. And money is always important so that you can afford the rest of things in life. But these number 1 and number 2, 1 to keep you creative, a hobby, photography, whatever you might choose, and always come back to exercise. Things money can't buy, though. Happiness, inner peace, integrity, character, manners, morals, etc. So don't go after money alone. Make sure a rule never to think twice about investing in yourself. Books. And I recommended a book that I think that all physicians should get, Emotional Intelligence, Quality Food, Being Fit, Personal Development, and invest in your mental health. Very important. And it's not only decreasing the stresses of life, but adding something pleasurable to your life has more benefit than simply trying to reduce stressful events. And Christmas is coming. And those who avoid overindulgence and family squabbles will enjoy a postprandial rise in their blood sugar, and this will prompt a flood of endorphins. Good food, nice food, chemicals that act as your happy hormones to rush through the brains. And all of us gonna hopefully have a good Christmas. But the pleasures goes deeper. Animal protein, such as roast chicken, ham, fish, contain all the amino acids that the body needs, including many it cannot make itself, as you know, tyrosine, tryptophan, etc., to make to that you can have an increase in dopamine, and that you can feel the pleasure and rewards, and serotonin, which help you to regulate the mood. So having some good food during Christmas is, and on an ongoing basis, is going to help to one of your stress relievers. And also the Brussels sprout contain food. There's a big connection between food and your mood. And bad food helps you to, food that is not healthy, gonna also affect your mood. Gonna encourage you also to indulge. Take a day off to spend a whole day doing exactly what you want. Eat what you want, watch a series, anything that you as an individual need to do to make you feel better. Not what your spouse wants, not what the children want, not what the patient wants, but you need to indulge in yourself so that you can bring down your allostatic load so that your non-communicable diseases will not happen, or those that already have non-communicable disease will be able to manage it more effectively. Exercise, and everybody I know that is listening to me today knows that 30 minutes of exercise daily, and my recommendation is a brisk walk, 30 minutes. But I wonder how many of us do that at least 5 times, preferably daily. When you do that, you ward off depression, you ward off anxiety, and your brain is more active and thinks better. Walking helps to clear your mind. If you're feeling bad, if you're feeling unhappy, if you're feeling agitated, if there is a problem, acute problem, might help if you go for a walk. Walk helps to clear your mind, and it offers a different perspective. And we in Jamaica have such beautiful surroundings that most of us drive past on a daily basis and we don't see. Very important that you sometimes live in the present and you see your environment and you be aware of your environment, that you can clear your brain and become more conscious and feel better. Walking clears your mind. Move your body every single day. We are made to move. Walking 30 minutes, etc. Keep it simple. Not meditation, that's also an excellent way to calm your mind, that you on a daily basis, you deep breathe in, and there are lots of YouTube episodes that will teach us how to meditate. Meditation is about calming your mind, focusing your mind on the present and not thinking about the future or the past, but being in the present. I recommend that on a daily basis, in the morning, before you get up, you slide off your bed and you do a 30-minute at least of a plank. And then before you start moving around, you do 15 to 30 minutes of meditation. If you can do that on a daily basis, if you make it a habit of doing that on a daily basis, then I guarantee your mental health, your sleeping pattern, how you're feeling will become much better. Deep breathing exercises, if you are in a situation where there is acute stress and you want quickly to bring the situation under control, deep breathing, and I know you all know about the 10-10-10 deep breathing. This will help to lower your blood pressure, break the stress cycle, and help you to manage the stressors. And if you do deep breathing on an ongoing basis, then the clarity in your mind will become better and you'll be able to function better, ward off anxiety and depression. Discuss feelings. Many of our doctors don't like to do that. There is no problem, bar none, you should have that you shouldn't talk to somebody about. When you talk to somebody about your feelings, what they are doing is loosening up the emotion that's attached to that specific circuit in your brain. And therefore you release some of the emotions around that. The more you talk about it, the more you release the emotional attachment and the feeling. So there should be no problem that you shouldn't talk about. people who talk a lot, always talking about the problems, some of this research shows that they live longer than people who bottle up their emotions. They might cause the people around them not to be too happy, but they are getting it off the chest. Not talking about talking to resolve the problem. I'm talking about talking about the problem to get it out of your system, get it off your chest. Very, very important that regardless of the problem, you talk about it. And sometimes direct communication may not even be necessary. Writing in a journal, write it down, composing a letter that you don't have to give might be helpful. No man is an island. Very important that you have support system. If you don't have support system, then your lifespan is not going to be as long as it should be. And sometimes, although I talk about discussing all problems, sometimes silence is important if your words can destroy friendship. And remember, some things have to end for better things. Sometimes you have to move out of your present job or go to another so that you can start a new life. If the present situation is toxic, instead of hurting yourself and making other people around you comfortable, sometimes letting go and moving on is going to be important. So if you overthink, write. If you're anxious, move. If you're tired, read. If you're confused, walk. If you are sad, exercise. And also remember, in our society, we need to socialize our men differently. Men can cry, they can have anxiety. Well, more men get abused, they get depressed, they struggle with trauma, they have eating disorders, and in our situation, the highest number of individuals dying from suicide are men. Finally, satisfy your soul, not society. And remember, sometimes you win, reframing your thoughts, sometimes you lose. All of us have iPhones and phones. You wouldn't let this happen to your phone, so you need to take care of yourself. And the serenity prayer, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. And that is the key. Living one day of a time, enjoying one moment of a time, taking this world as it is, not as you would have it. And for those of us who is moving on in life over 50, and for the young ones to remember, the report says that self-reported well-being on a scale of 1 to 10, and I hope you remember when I asked your scale of 1 to 10, the number that you said you were. When you're young, 18 to 26, 24, you come down, and then there is a up kick, and then after 34, the satisfaction of life dips until you reach around age 50. And the research shows that there is an upward trend from that time until you are in your 70s, 80s, right? So those of you that is looking towards the latter part of life, remember that the life satisfaction as you get older. It's not that you have a satisfaction that's going to go down. Your life satisfaction, well-being increases or should increase as you grow older. And we were not, I had this here, where that suicidal thoughts in the different specialty, but I won't go into that. And lastly, the recommendation, strongly recommend that you get this book. The Body Keeps the Score, Brain, Mind, and Body in the trauma, in the healing of trauma. But it really talks about that whatever happens to you from age 0 to whatever age you live, the body always remember. All right, some references, and thank you very much, and we can talk. Thank you, God bless.
Dr. Wright, I don't know how to thank you for your presentation today. Absolutely enlightening and covering the gamut from our children to our patients to ourselves. I would just like to mention a few points that you brought up, because it's been an excellent presentation and many of us need to hear what you said. We need to self-love. We need to love ourselves so that we can function and adequately treat our patients. So we thank you for telling us about the children and their brain and emotional development, and how to recognize in our own selves our own mental illness, our own problems. We want to thank you for teaching us or showing us how we can go about managing some of this. And also that we need to understand other people's perspectives, and that other people are not necessarily wrong. They are not wrong. They're just sometimes just saying something in a different way. We need to realize, and it's really something to recognize, how our children's brains develop and how they are influenced from their birth by the things that are happening to them in their community, and how we should try to minimize and to prevent this disruption in the development of these children, their brains. So how we prevent antisocial disorders, violence, lack of productivity, and all eventually the prevention of uncommunicable diseases, toxic stress. You have taught us a lot here today. You also mentioned to us about this CAT scan, the PET scan, which was very, very, very illustrative. That normal brain as opposed to the abnormal brain in the child, it spoke for itself. And your mention of the NHF subsidy for children and for mental health disorders, which is inadequate. We all need to, you mentioned concerto. We need to push for this. We all as practitioners need to advocate, send in our request that we have more access to these medications for our children. The NHF does listen to us when we ask. So many factors lead to poor mental health in children. We also want to thank you, Dr. Wright, for talking to us about a little bit about burnout, chronic stress causing burnout, emotional burnout, cynicism, fatigue, detachment, negative attitudes to our work, which erode our compassion and make us inefficient in what we do. 40%, you said, 40% of our community has personality disorders. And that is 40% of us who are listening to you now. It is something to realize how our midbrain emotionally hijacks our executive brain And if we allow it, it takes over. And we do not react as we ought in the situations when we look back. So long-term stress, which is such a risk factor for chronic diseases. You spoke of cortisol causing diabetes mellitus and or noradrenaline, resulting in higher levels of hypertension. We cannot control others. We must accept that we cannot control others. We can control our actions, our thoughts, the time we spend, the reactions. And you said to be true to ourselves. Christian principles: treat others as you want to be treated. Learn from your mistakes. No man stands alone. We need each other. The more we give, the better we feel. Ask for help when needed. Take time to enjoy your life, your own self. Create hobbies. Have 3 sections there. You said creativity, exercise, money making, invest in ourselves. Exercise is treatment which clears our minds. And invest in daily meditation to improve mental health, improve our sleep, release stress through talking about the problems that we have. And you're not just trying to come to the solution. Just find someone you can talk to, speak about it, get it off your chest, as you said. So we have to satisfy. I think we have to satisfy something within ourselves. We have to clear things within ourselves in order to be productive in our society. And we just want to thank you. I spent those few moments just to see how awash I have felt by your presentation today. It has been a gift, sir. So I thank you very much. And at this point, I'm also going to thank Dr. Frankson for his efforts earlier on to present to us on medical ethics and a number of things, which what he's going to do for us is to provide us with a video of his presentation tomorrow, which will be shared with this group of participants. He's also back on board with us as we go now to our Q&A, and I would like people to address questions to both of them as we move forward. We have a lot of questions for Dr. Wright. I'd like to remind you that Dr. Frankson spoke to us a little bit of our history, from Socrates, Judeo-Christian views, to applied ethics, and gave us a little bit of our history of the Hippocratic Oath, which I really didn't want to think could have not been from Hippocrates, but I believe in Hippocrates. And he spoke of ethics, fairness, justice, truthfulness, respect, the concept of what is right and wrong, and logic. He spoke of fairness and beneficence, autonomy, consent, confidentiality. He mentioned the Data Protection Act and how some aspects of it may prove in the long run to be unethical. It's very topical, that as well. So we're going to turn over and open up our mics. We're doing some Q&A for now, and we want to get on board with the questions for both speakers. Let me see what we have. For starting with you, Doc Wright, there's a question that says, why should you encourage people?
All right, you freeze. Let me turn off my. Freeze. Not hearing you. I think if you can turn off the videos, might do the broadband. Hello?
I'm hearing you, Dr. Wright, but.
Okay, but I'm not sure anybody else is. All right, we'll see how it goes.
Maybe they could indicate whether they hear you or
Hearing you,
not.
Dr. Wright, hearing you.
Okay, here I am then.
Oh, you shifted your position. All right.
What has happened, of course, is that I've joined Dr. Frankson. I seem to have lost my, I've lost my Wi-Fi link. So I'm now on my telephone, my cell phone. So I'm going to ask Tafari to go ahead and ask the questions for me as they were presented in the Q&A. Tafari, please ask them. Go ahead.
I'll get those for you one.
Go ahead, Tafari.
Okay,
Or
we
is
have
Dr.
one.
Wright finished with his answer yet?
No, we didn't do that. Let me just answer that. Let me just go right to the first thing you asked. The person was asking, I'm not encouraging people to go overseas for basic treatment. What I was basically saying, because I lived for a long, I was trained in the United States for my special degrees, and I live there for some time. So, and my children are there. So I go there intermittently for some treatment. And when I go, they always ask. The nurse asks me straight, and I heard Prof. Abel say the same thing. The nurse asks you about the two questions, the two screening questions that's on the Ministry of Health screening tool. And then the doctor asks you those two questions. We are not doing it here. Let me be frank about that. Most doctors are not asking the two screening questions for depression. And if you are depressed, it's going to affect all your other illnesses. So it's going to be important that we systematically screen for depression, just like how we screen for hypertension, so that we can manage the 20% of the population that have clinical depression. I hope that answers your question.
Tafari, go ahead with the next question.
Is the MAJ's ethics comp still active and working with physicians with emotional problems, impaired to practice correctly?
Sorry, say it again. Is the MAJ's
ethics
yes
still active and working with physicians with emotional problems?
For the MAJ, I don't think it is as active. I'm just speaking off my head now, but I do not think it's quite as active as it used to be. I think we could ask Dr. Wright to speak a little bit more to medical councils.
We have a wellness committee at the medical council that if there is a problem with an impaired physician, it can be dealt with. I think the MAJ also has a health committee that deals with impaired physician. But the problem about impaired physician, it has to be reported. And many of us might know impaired physician, but not prepared to do anything about it or to help them. Because really, an impaired physician is usually depressed, substance abuse, or very rarely you find an impaired physician with, well, as they grow older, some might develop dementia, but all of that, the health committees can take care of or help them with.
Awesome. Thank you for that answer. Another question. How can we deal with the stress caused by the stipulation of the Data Protection Act?
Well, it comes under the general managing your stress. I know some of us are having increased stress as we did with COVID, with the Data Protection Act, but we're talking about the usual stress management techniques that we went through at length. The daily exercise, the meditation, the talking about. But as you increase your knowledge about the Data Protection Act, then the stress level will decrease. So it's going to be important that all of us get as knowledgeable as possible about data protection.
We could also ask Dr. Frankson for his input right here on the Data Protection Act and the ethicalness of it and of its as it applies to us, because we, as he spoke to, have always have our Hippocratic oath. We've always been there. We've always had it. We've always assumed an ethical stance for ourselves, and many of us are finding this an imposition.
Okay, there is good and bad in it, potentially, and there is right and wrong in it. The act is coming from basically a good place. It actually is helping us to have more security and confidentiality for our patients and in the keeping of our records, and also in being able to share it in responsible ways and so forth. The issues that are there that can probably, in my mind, be questioned is not so much the act, but the environment in which the act is playing out. Are we ready for this infrastructure-wise in our medical establishment? We have we still have too much of a hospital-centric healthcare system where we are actually looking for a lot of our care at a hospital. The worst part of it is the emergency department, where some people actually believe that that's where you get primary care. Very wrong concept, but actually the reward is that if they go there within 24 hours, even if they have to suffer and wait all night, they get all the lab tests and the results right away, and they get a diagnosis and a referral. So it reinforces them wanting to come back again, even though it's a very, very tedious process on a human being to sit down and wait through that emergency triaging and so forth. What is the Data Protection Act going to do with that? With an emergency medicine physician who is really a general practitioner, but is convinced that he or she is a specialist, and who will therefore see you in fragmented ways.
immediately addressing your emergency that you have. Record will be there. Your documentation will not be comprehensive, and overly, you probably will get referred just to get you out of the system. And if they're unsure of what's happening, you'll be referred to a specialist. I know psychiatrists, Dr. Reed, are very frustrated with the amount of referrals they have for court remand, where on the emergency side, and we have done research on this, they find absolutely nothing physically wrong with them. All the lab tests keep coming back perfectly well, etc. But it is not a very welcoming area for that. But primary care seems to be the answer. And if primary care is moved into the center of not just being a convenience, but a requirement that you really have everything focused through primary care, coordinating it. That's one of the reasons why I call it an extensivist kind of thing, because it's kind of what the hospitalist does in the hospital too. They coordinate all the different specialties, input on a particular patient, especially elderly patients who have multiple pathoses. And then they can speak to the one patient, and it really becomes a person-centered kind of approach. Well, we need that in the community too. We need, seriously, far more than we have here, primary care, and there's a battery of them, internal medicine, some ONG maybe, some pediatrics maybe, and of course the family medicine and the general public health physicians as well. We need to get our act together where we can have those things so well coordinated that the access is there to us by the patient, the records, the Data Protection Act requirements gets fulfilled in a more holistic way in that setting, so that when you actually now need to refer a patient, which you oftentimes do because sometimes it is beyond the scope of your practice, for a specialist care by some member of the health team, a lot of times a physician, but sometimes a physical therapist, sometimes a medical social worker, etc. If you have that hub, then the Data Protection Act will work very beautifully, because primary care is really the key one that has all the holistic information, and if it's cooperated with, can get the other pieces of information from the other specialties. And then now it can put the picture together so that as you are referred, and it is person-centered care that you are getting, where your personal needs and your personal situations, etc., which actually is what Hippocrates and Hippocratic physicians really did to change medicine. They started to pay attention to the whole patient, rather than what itinerant physicians used to do. They used to go by and pass by your homes. There was no hospitals in Rome, for example. If you got sick, like with the plague or whatever, they would build a quick shed, keep you in there, and as soon as nearly everybody dies because treatments weren't great, they would burn down the shed. And it's called a valetudinario. That's how they used to run housing for healthcare, and etc. But all of that has gradually changed now, where we're enamored with our hospitals. What we need to do now is to move to the next stage of being enamored with primary care. And primary care needs to step up and be really the kind of holistic, capable entity. The Data Protection Act if that happened, the Data Protection Act could then bring less harm, more benefit, and actually ensure better confidentiality, or at least foster it as other areas of respect for autonomy. And access, which is really about justice.
Thank you. Thank you so much, Dr. Franson. There's another question here for Dr. Wright. It asks, re-IQ. Dr. Wright, this is for you.
Mm-hmm. Yeah.
Re-IQ. Which doctor do you want to treat you? The emotionally intense, lower IQ doctor, or the lower achiever filled with plenty political savvy, or the doctor who has the top high functioning IQ, who gets better results, oh dear, than doctors who focus on administrative advancement? So it says, do you want, which of the doctors? You did speak to two different types of persons. I
We're
guess this is the question
talking about who I want to treat me is a doctor who treats not only the physical, but the mental, and treat a comprehensive person, a well-being, focus on well-being rather than one aspect, or always taking the emotional component into their treatment, because you cannot separate the emotional component, the brain component, how that individual's brain is functioning from the rest of the body. So I want somebody who do both, not going into the political part of it.
Well, of course, the idea, of course, is that how can you know you have a good doctor? If you have a good physician who's functioning well with you, you have no way of knowing if that is a top 10 IQ type brain, or if it's a moderate brain functioning very well within its for you within as a professional. So you actually have to accept what you experience. It speaks for itself. There's another question here for you. I think it speaks to the COVID issue, and it asks if you think that the COVID issue was explained by hysteria that led to doctors shutting their offices, causing more deaths. Now, to be honest, most of the GPs I knew were very, very much out there at work. I don't know that there were that many GPs who actually closed. But I'll put the question to you, as said.
I don't know if I think doctors were out there. That's why we lost some of our doctors. They were out there and doing the best they can and helping patients as they should. I'm not sure about the doctors being hysterical and closing their office. Not aware of that. I don't know of any doctor that was hysterical and closed the office. So I can't really talk to that.
Okay, the same person asked, oh dear, this is about Gaza. Finally, what is the highest human quality achieved in Gaza when these doctors refuse to abandon their patients? They're speaking to something good. The doctors and their devotion to their patients and their unwillingness, or the fact that their ethical nature would not allow them to abandon their patients. Perhaps yourself and Dr. Frankson can address this.
I'm going to leave that to Dr. Frankson.
I see here the person said it's a question for Dr. Wright as well.
Well, repeat that for me, Doctor.
All right. So, what is the human quality? This quality being achieved in Gaza, where mentally and I guess ethically, where the doctors have died because of their refusal to leave their patients?
Well, it speaks to the empathy, it speaks to our sense of responsibility. It speaks to how much we feel about our patients and what we need to do for them. And I think many of us go, in Jamaica, we have limited resources, and many of us go out of our way to provide whatever we can to treat our patients to the best ability that we can, working exceptionally long hours. And that's why the whole thing about burnout is important. Many of our doctors are getting burnout right here because of the limited resources and the long hours. So it's a similar thing to those doctors in Gaza. That happens they put themselves doing the best for the patient, sometimes doing harm to themselves and putting themselves at risk.
Thank you.
I think also there's a ethical component that maybe Dr. Frankson can address.
Over to you, Dr. Frankson.
not there.
He's gone? Okay.
I
All
said,
right.
there's another
Dr.
question.
Franklin is coming back on. I see he's muted though, so we're not hearing from him. Dr. Frankson? Oh dear. All right. Safari, please go ahead and read another question for us.
Sure. Here we go. Do you think we should be allowed to take mental health days off for when we are overwhelmed and know our cups are overflowing and unable to adequately care for our patients? Another part of the question also, should psychiatrists have psychologists? I think that one is worded a little bit weird. I'll read it again. Also, should psychiatrists and psychologists be seen regularly?
Okay, let me take the first part. Mental health problems are brain problems, organ problems, just like how you give sick leave when a patient's diabetes is out of control and the patient isn't feeling well, or patient is hypertensive and have a problem. Then there is just like when the brain isn't functioning as well as it should, and the patient has a mental health problem, they should get sick leave. And I give patients sick leave for mental health problems so that they can adequately take care of themselves. Mental problems are brain problems, so you treat it like any organ problem. The other part of the question also, should psychiatrists and psychologists be seen regularly? Well, when I was trained, in order to complete training, you had to do psychoanalysis with one of the senior psychiatrists. So you did a psychoanalysis, or you did some sessions so you can get to understand yourself and manage yourself better. I think it's helpful. I'm not sure that they should be seen on a regular basis. Number one, I don't know what regular means. But I think if the psychiatrists or psychologists start having, they should be able to recognize their problems early. If they start to have problems, then they should go to see somebody as quickly as possible. And also their colleagues, if some one of them is not doing what they are supposed to do and you see them having issues, then you should be concerned and reach out to take care of them. So I'm not sure about seeing on a regular basis, whatever regular mean, but they should also be seen.
Thank you. I wondered if Dr. Frankson, are you back with us? If not, I'm referring to in the chat a comment from, oh, okay then. Your time while you're with us, so I'll take the chat up. You were speaking to the Gaza, the doctors in Gaza, and their decision to stay with their patients and to die with their patients. How far do we take this ethical business? How far do we take, how ethical is this? Is this beyond ethical? Or what is really required of us ethically in these sort of traumatic situations?
What has been clear as we have matured as physicians over the centuries is that medicine is not a business. It's not just a practice, it's a ministry. And it really comes with an oath, and it's not a shallow oath. It's a heartfelt oath and a commitment that has lifelong implications. What that means is you're ministering because there is an enemy, and the enemy is disease and death and poor quality of life and shortness of life, etc. And you're really trying to, I know some people say death is a part of life,
I think this is just an ending of life, or some people say a comma in the sentence of life based upon their belief systems. When you make such a commitment, and after going through the kinds of training that we have gone through with our tutors, our teachers, our mentors, putting the kinds of demands on us, you become a totally dedicated person to bringing people back to good health, and sometimes just to good basic health, although the thrust these days is towards, even beyond that, to wellness. When it comes to that diabetic patient who is in ketoacidosis and coma, we will go night and day to titrate that person's blood sugar back down to normal and bring them out of the coma. And it pulls on our lives. When we choose to work at certain places, I remember I was working in ENT, and one of the reasons why I came back into community public health was one of my classmates was one of the top inspectors of police in Kingston. And for the third time, I had gone in and taken bullets out of his temporomandibular joint area. And I said, enough, somebody has to go and turn off that pipe up the road. So I might just get a little pipe to turn off, but I will take my little pipe and I will add to all of those who are turning off pipes. In other words, doing the prevention approach. Well, that is true for prevention, and it has not been the most lucrative of my choices. However, I've been absolutely satisfied. I've gone to work in Trenchtown for 6 years, and one day I looked out the window and saw one of the young men. I picked up my son from halfway tree, and I'd just asked him to hold on because I would finish up my clinic and then take him back to Havendale where I lived. And I looked outside and saw him being educated by a resident, a little boy, on the different parts of a gun, a live education, etc. And I told him, of course, not to tell his mother. And the first thing he went home and told his mother that he knows what a gun is now. I see that didn't stop me from going back to work. At times, I would go down to Trenchtown and they would just call me over to the apartment buildings to see young men who were disciplined by a neighboring community that had been in control of them, by coming in and just lighting them a fire and burning them all. I can still smell the smell in my nose of the charred bodies. And this was all in the early 1980s. And I still went back to work. I understand what it is like to do that. You try to develop safety measures, you try to develop rapport. One of our hallmarks of primary care that we were able to pull off very well on that USAID funded grant was we were expected to have the community share in the management of the pilot project, primary healthcare program. And because of that, the community were our allies, and they would help to give cues as to when you can come into Trenchtown, when you must stay out, and things like that. I suspect that in Gaza, etc., much of that dynamic is happening, maybe not as in a structured a way as primary care would have it, because this is a crisis now, it's a whole different ball game. But I could say a lot more, but I'd stop at that to show that really we have a duty of care that is not normal. And it demands for us to step in like a soldier against the enemies that we are sworn to defeat. And we do it, but the talk today by Dr. Wright tells us how to do it balanced. And I thank him for that.
Thank you so much, Dr. Franson and Dr. Wright, for this moment, this actual moment of unity. I want to say though, what would happen if that doctor had left? If that doctor, Gaza, or yourself, Dr. Franson in Trenchtown, if seeing the community under barrage, as in Gaza, they're dying. I think that it's over 200 dead since yesterday or the day before. Again, what happens to the doctor who says, I am going back to my family now? They need me. They're little, they're young, and they are very, very much at risk of not having a future if I were to be killed. What of that doctor? Do we blame this doctor? How does this doctor move forward? How do we accept that as an adequate result also? Where is that doctor ethically? Dr. France?
Every doctor has the same rights as the patient or her patient. Every doctor, including to preserve yourself and to expect the best in life, etc., and to respond, to be there for, be alive for your family members, etc. The difference is, though, that we are the ones who have the authority, and with that kind of authority comes a differing of some of our rights to those who are more vulnerable and less empowered with authority in moments like that. And that is why we go in for infectious cases. We go, that could be also an Ebola case or a coronavirus case that more to be more present with what happened here. That's why we go in, and we have not only that sort of a differing of a right of our rights, but we also have that heavy duty of care, and we also have to make sure that there is, while we're delivering that care, there is as little harm as possible to either party. So we have the rights to do all the measures that are the infection control measures or the war-related measures, etc., that are there. A doctor who foolhardily runs into an active firing zone, I don't think is acting in the best interest. But a doctor who times when to go in and does the best and may still get shot, well, that doctor has done their best. But doctor who times when to go in and refrains from going in when it is a horrendous moment is a doctor who is not being negligent and is abiding by the standard of care. And do remember that standard of care shifts from wherever you're practicing. If you are on the road with an accident and you know exactly what to do, but you don't have the things to do it with, the expectation of your standard of care is what other reasonable doctors would have done on the road with that accident or in that war zone with that situation. Your standard of care therefore shifts. If you now get that same patient with the same thing in a fancy emergency department, the standard of care raises tremendously, and now you have to do what other doctors, reasonable doctors, would have done in that same privileged situation where you have a very highly working, functional emergency department or ward or operating theater. Or there is standard of care too for community health. In a disaster, for example, or in a pandemic or whatever, it's a different kind of standard of care than you have for when you're in between such crises, when everything else is working well, etc. So there are policies that you won't be able to put out as fast because I remember the early days of the COVID pandemic. We were all stumbling. This was so brand new, but nobody went after our top doctors to get them fired because we knew that everything was so new to everybody, etc. But if it was something that was like the epidemic of hypertension and the poor management of hypertension by our patients, etc., even though it's killing more people than even the COVID probably did, we would expect much more wise policies coming out on that, but with much more harvesting of the international Zeitgeist, the body there of knowledge, so that our policies look like they could be workable in challenging situations like those of a chronic disease epidemic. How we would approach the epidemic of hypertension is quite different from how we would approach the epidemic of, say, COVID or another, God forbid, another outbreak. So all of that also has to be factored in. So sorry that I took such long time to round that up, but
So, well, thank you for
that's
Dr. Francis,
ethics for you.
yes, for saying to us that something that we may not have recognized, that in different environments in which we act, there are different standards of care which are applicable, because sometimes some doctors will see a situation on the road and will tend to avoid letting anyone know they are a physician, because they do not feel that they can work in the way that they would in their practices, and they worry about that standard of care and being held to it, and also the results of poor outcomes in that environment. So this is very important for us to know.
Just add one little thing, and that is, no matter what your standard of care, if you even have to find a piece of brown paper bag or exercise leaf book, document it to some extent what you have just done, because that is at the minimum that you can do this many times. If you just write it on a scrap of paper.
That is why really, doctors will walk by and avoid the need for that scrap of paper in case. Dr. Wright, I have a question for you. Well, a comment really from Dr. Mindy Fitzhenley in our chat, who says that psychosomatic disorders are diagnoses of exclusion, and everything else has to be checked first. And I will ask you to comment on that.
Well, one of the things about psychiatry, we need to rule out the physical conditions before we make a diagnosis of the mental conditions, because there are many physical conditions that highly treatable, and if you miss them, it might end in a mortality. So we have to rule out all of the physical conditions, and that's why psychosomatic disorder, you need to rule out all the physical possibilities before you make the conclusion. The reason for that, an MRI isn't going to show you the disorder that's happening in the brain. We are not at that stage yet. We are getting there, because we now can see the amygdala being more when it's healthy and when it's not healthy, and the hippocampus being healthy or not. In depression, you're going to find that the hippocampus is shrunken by the cortisol. So we are getting there, but we are not at the stage yet where we can have we can do a blood test or a MRI and see what's happening in the brain. That's why we have to rule out all the other conditions physically. Hope that answers me in this question.
Right. I have a question for you.
Go ahead.
It's one about when you talk about how we need to love ourselves, and how we need to see ourselves, how we need to recognize that we may be acting with our hippocampus rather than with our executive brain, and how we need to actually harvest that activity, the negative activity as well as the positive, into positive outcomes. And I want some guidance from you as to how do we do that. And as a part two, in situations that happen in our lives, we know we have heard you today. So theoretically, there is this knowledge of what you should do. How do we do this? How do we actually move on from the traumas that affect us within our working lives? And how do we move on from the traumas that are affecting us at home? How do we heal? Is there ability to self-heal so that we can function at our best levels? That's two questions.
That's the thing that Mindy was talking about. She was asking about how we psychiatrists, how do we heal ourselves, whether we should go and have talk therapy on a regular basis or not. Well, you might not have it formally, but we need to have social outlets as to support systems under the rubric of support systems as to how we help ourselves and get support from others. The other part of it is it's the usual stress management. You have to take care of yourself by first making a decision that as of Monday morning, tomorrow morning, you are going to do all the things we talk about, the exercise, the talking about the problems, the meditation, the making a positive efforts to reframe, rethink. When something happens, you look at it. There is no problem that you can't learn something from or reframe. So you have to make up in your mind, what is it you're going to do? If there is a severe traumatic event, then you have to deal with it more effectively. You have to do all the stress management techniques. And then if you're having major problems, you're not sleeping, you're not eating, you're not dealing with it well, you're anxious at work, then you need to see one of us, the psychologist or the psychiatrist. If you make a diagnosis of depression, and we talk about screening for depression, and remember, doctors are no different from the general population. So I would expect that many of the individuals, the 431 individuals who are listening now, you're going to have between 10 and 20% of these individuals having symptoms of depression. And I'm saying they also need to treat it like they would treat their patients. If they're not sleeping, they deal with it, or they go to see somebody if the symptoms of depression, or you do the things, the stress management things, the sleep hygiene and other things so that you can move from one space to another. But you have 432 people, and just like you have a number of individuals in this audience who have diabetes and hypertension, and they take their medication for their diabetes and for their hypertension, the same way, if the 11% plus that have depression, the depression needs to be treated also.
Thank you, Doc.
I'd like to answer Dr. Bacchus. Very important question.
Okay, you still question. Go ahead.
He says in the first 5 minutes, I outline the brain development and adverse childhood experiences, how it shapes the future behavior. And he talks about a lot of hostility that is started in homes by parents, and how do you think we can address this problem nationally? Let me talk about the health system and primary care. It's been a long time ago, when I just came back to Jamaica in the 90s, Dr. Samsbourne did a study and a profile that talked about the need for reliability of patient care and taking care of children and the problems with violence in the home, etc. And then later on, Professors Sally McGregor and Professor Dan Lopez also did a study where the community health aides went into the homes of children and stimulated them, talked to them, and they did a long-term study on that. And it was shown that these children had better outcomes, better productivity later on in life, the early childhood. And they also show that the depression of the mothers decrease. That's the community health aid going into the home and interacting with mothers. It's been shown internationally that home visiting programs where community health aid or nurses go into the home and interact with the family, this is extremely important We have the infrastructure. I was a medical officer of health long here, so I know we have the infrastructure, and we are one of the better primary healthcare systems. We have the infrastructure where community health aides can go into the homes and interact. The research has been done here, and the outcomes have been proven, and that study have been implemented in Pakistan and Brazil and some of the other countries, but it's not been implemented here. We need to implement that program so that we can have the healthy, loving interaction in the home. And then we have what I propose, and some of you would have read the article that I wrote in the MAJ supplement, where we talk about gentle parenting. We need, if you have corporal punishment, if you have the modeling of behavior of violence in the home, then you're going to have the perpetuation of violence later on in life. And if we have a high incidence of adverse childhood events, we are going to have an increase of the diabetic non-communicable diseases. So we're talking about the health sector doing something actively in the first 3 years of life when the brain is developing at the highest, the most rapid rate. And the other part of it, after that, now the education system takes over and continue. But if we are going to change things and we start now, then we can get it better in 15, 20 years, a generation. There is no quick fix, but the health sector have a pivotal role to play where more than 90% of individuals interact with the health sector during the early years. And also, during that time, parents are very receptive. So parenting, effective, gentle parenting practices can be taught.
Dr. Wright, both yourself and Dr. Franson keep referring to the primary healthcare system and the huge role it is actually playing in the future development and of our healthcare system, successful development, something that actually makes a difference to our population. And so there's a lot that's happening that needs to be focused on these primary care physicians. And
Can I just,
yes, go ahead.
can I just rudely interrupt a little?
Go ahead.
Much of my presentation today would have come from this book here, which is a World Health Organization 2009 report, or it's 2008 or 9. It says 2008, and it's free on the web, so you can get it in PDF. Primary health care, now more than ever. That was the theme. And the whole concept was that nobody has gotten primary health care really, really well to the potential that it should be. The richer countries, some, for example, people who refer a lot to Canada, for example, have done a very good job. And primary health care is not the same as basic care. Primary health care is community-oriented, community prevention-oriented, well-coordinated, holistic care of those who are in need. When we just came out of Alma Ata, we used to talk about essential things, the more common diseases. Primary healthcare does not talk about that anymore. Primary healthcare talks about anything that you come with should get that level of well-coordinated linkaging going on so that when necessary and you need to be referred, you can be. But most times, the linkages would have come back and even prepared the primary healthcare people. For example, we all know of the MH gap, mental health gap. initiative that is to be incorporated into primary health care. That has been a blessing, many places have found. And it has had the care of folks in a less stigmatized environment. And it has had them having ready access, if they have other comorbidities, to getting conjoint care, etc. The same has been true for HIV/AIDS when it was moved back into primary health care. And that's a serious infectious disease with large ramifications. But if you have the attitude that you want an easy life, so you're going to primary care, that's when you're going to make trouble. That's when you're going to see more doctors joining it, but you see the hypertension rate going up. You see the heart disease rate still going up. More physicians are employed, but all the epidemiological trends are moving in the wrong direction. So it is primary health care is as hard as neurosurgery, etc. And it needs for us to have, when we're going to have an attitude of being the best at what we do there, because we are, especially when you talk about person-centered care, where now you're tailoring your care to the real context of that patient, because research has shown that that is where you get the best results. That is not just, I want an easy life, 9 to 5, so I will go to primary care. No, that is a big, big mistake. It is, if you go with it with the right attitude, where collaboration is really what you are about, you want to learn more of these techniques, that will help you to be extensive, to be a great generalist. And you know, what you might be as a great generalist in Savlamar is different from what you might be as a great generalist in Falmouth or in Spanish Town or in Mona, etc. Because it's needs driven, and the needs are different in Savlamar. The needs are different in Falmouth. The needs are different in Spanish Town. The needs are different in say Mona or whatever other places, to name just those for example. So I just wanted to underscore that please get this book. It's easy, it's free. Primary health care now more than ever. World Health Organization report.
Could Dr. Wright also mention the book that he suggested we get? Is Dr. Wright?
Yes, and this is last one before I go.
Okay.
The other year, to back it up, was Health Systems Financing, the Path to Universal Coverage. These two were the sources from which much of my presentation is based. So please go get them, and you'll be light years ahead of my presentation.
Yeah, put them in the chat, Doc.
They are part of my presentation as well.
Yeah.
And so you will see them as you go through the slides. I have one slide dedicated to advertising them.
Okay, because I'm also suggesting that you could write it in the chat so that people.
Oh yes, absolutely.
Okay. I guess I'm also there were a couple of things in the chat that were just comments that I seem to have lost my chat. Let me see back my chat. There was a comment from Dr. Buckley on the boat, putting on your oxygen mask first. What's it we're seeing now? Sorry, what are we looking at now?
I'm just showing you, you asked for the
right.
The book. There's the book. The Body Keeps Score. Are you seeing it?
I'm seeing something about cardiovascular risk assessment.
Oh, that one. All right, I'll come out. I'll stop sharing. But the cardiovascular risk assessment you're not gonna see that. I would like to share this with you so that you can. Are you seeing the diabetes, hypertension, primary care consultation, and on
Yes.
it to have the depression screening and drug abuse screening. This is from the Ministry of Health, right? So what I'm basically saying, it's been accepted. I don't think they're doing it at the university or socializing their doctors about these screening, but just as how you screen for the other things, your hypertension, you should be asking these two questions on an ongoing basis. Just want to emphasize that.
Thank you. And there are a number of commendations and accolades in the chat for you both, and wonderful presentations. That's from, who was that? No, it's another person saying the workload is a challenge for most doctors, which we know is true. We can't get away from that. I think we have to know that that's a choice we make when we come into medicine. And it is certainly something that you have to cope with using the precepts that Dr. Wright has suggested to us in these presentations today. Someone here says, thanks, Dr. Wright. There was another question. What do you think of oh, this is Dr. Hunter. What do you think of patients waking up every day to another of their fellow patients, with families who were with the patient at home? I'm not getting it. Completely block the same family from seeing their relatives. Well, I think it's a COVID-related question. I don't know that we can answer that here. Opal Davidson says, very good support in attendance. I'm happy for this initiative where doctors and psychologists can interact for better healthcare management. And we move, I'm trying to see if there's anything else before I move a vote of thanks. Tafari, am I missing anything much before I move on? As Dr. Wright said, Christmas is coming. Christmas is coming. So yes, and I have a big smile and feel good feelings about Christmas coming. Anything else, Tafari, before I move on here?
No, I'm not seeing. I think you covered it all.
Okay, so take time off, take time out to enjoy life, to enjoy yourself. Exercise is treatment which clears our minds. Daily meditation improves mental health and sleep, releases stress, and also release stress through talking about it. Satisfy your soul. So with that, I am now reached the point where I would like to give the vote of thanks. They say that parting is such sweet sorrow. It has come to that time of day when it is my privilege to thank everyone who participated in this outstanding medical, ethical, and mental health symposium. Firstly, I would like to thank our presenters, Dr.
Doc, before you go any further, Doc?
Yes, go ahead.
Dr. Buckland is supposed to do the vote of thanks.
Oh, it says vote of thanks moderator. So that's what I have on my my thing. Okay, it says vote of thanks moderator. So I will, but I still will hand over to Dr. Buckland. But I would just like myself to thank those individuals who participated, our speakers today, who brought to us a lot of medical information, providing much food for thought. You know you have achieved your goal when it inspires change within a group of people. And so I would like to thank you too for participating with us today. And I will hand over to Dr. Buckland at this time.
Thank you, Arna. You did a wonderful vote of thanks. Thank you very much. So, you know, it has been such a tremendous conference. Firstly, you know, with Lynn and the whole preparation, and with our engineer getting the webinar going, and then even our presenters. They did such a wonderful job. It was not very easy, you know, because we had certain glitches, and yet our first presenter, Dr. Frankson, was like somebody on one of those surfboards, and he just rode the wave with such glide and dignity, you know. And he rose again, and he just faced the waves. So Dr. Frankson, thank you so much. You know, you did us really proud, and you shared what you needed to share, and with such persistence and diligence. Thank you so much. Also, our second presenter, Dr. Earl Wright, I thank you so much for taking us through the whole gamut of mental health care, and that really we need to take care of ourselves, to look at ourselves in certain ways, as you have shown us. It is really important that we do put on our own oxygen mask first, so that we can be really effective caregivers. Because when we don't, you know, we could actually respond or speak to somebody in such a way that hurts the person more. And sometimes those of us who are hurting, we need to call our own mayday and just seek time out. Go to your supervisor and just ask for time out. If that's not working, you go to your doctor, be examined, and get your sick leave. You're human like anybody else. We are human, right? We're not supermen, we're not superwomen. I know we're facing challenges with the new Data Protection Act, and it is a concern, because when we think that we have been really giving human service to the country, and it seems, this is how it appears to me, all right? So I'm speaking from my point of view. It seems that what, you know, I think I've been working hard with my patients, and then, you know, you're doing your due diligence, and you're facing this data protection officer, which you see is very important. The spirit of the Data Protection Act is important. It is good. But when you see this DPO coming in, and then all of a sudden these huge charges, it looks so unreasonable. Why would a system be put in place to now overwhelm a group of people who are trying to provide good health care to the country? You know, because all we can see now is that it's going to really hike the visitation fees to the patients. That is what it looks like to me, unless we as a community can find a solution, and where we get our training. We need to get training in such a way that we can be certified as DPOs. And then we look after each other's business. Just like how when Jamaica was facing a crisis, the government called on the pensions that the people had, and that rescued the economy. So I think as doctors, we're going to have to pull together and learn how to become DPOs and get certified and take control. We need to take control and not feel as we're being oppressed. Let's take control. We can actually turn this thing around so that healthcare can remain affordable and accessible. That's what I really think. So, so Dr. Wright, thank you for empowering us to think in the way I'm thinking, because I think that's the way out, because that is a major challenge for all of us. That is really a major challenge for all of us. I have a feeling that this cart has been put before the horse, but we will put the horse before the cart. I'm glad we do have 6 months. you know. But I think our presenters really, really did a tremendous job. And Arna, thank you so much for moderating this session. You really were fantastic and very gracious. And for all the participants who remained to the end, and we have learned a lot. And I wish you all a good afternoon. Thank you.
I'd like to just use this moment, Aldith, to thank you yourself for being such a wonderful person in terms of how you speak words. You speak positively and you speak truth and you speak powerfully. And
I'm speaking from the heart. You know, AGPJ, Association of Practitioners of Jamaica, we are going to find a way out of this mess. Because truly, we have been handed a basket full of mess. And we have to sort this out so it becomes fertilizer. We have to turn that mess into fertilizer, right?
Absolutely. And with those positive words, I would also like to thank our sponsors, Daisy Health, Indus Pharma, and Apotex for their crucial role in today's events and offering our physician cutting-edge healthcare products. Many thanks to our event planner extraordinaire, our administrator, as Ali said, Mrs. Lynn Thompson Hyatt, who is a fundamental part of every conference, webinar, or seminar that we plan. As we remember also Sam, and today his stand-in Tafari, having a role for us every time in these webinars. And thanks to the audience who listened, learned, inquired, shared, and generally completed a really fine day. We just want to thank you all. It had its hiccups, but we certainly proved that Doc proved, Dr. Franson, that he's certainly a Trojan. I know he has another one to go to now to another meeting. Thank you all for this blessed day. Thank everybody. Travel safe.